Once again, everyone, we are now going live so I can allow the other folks to come in, attendees.
All right. All right. Good morning, everyone. And thank you for joining us for today's conference, the annual St. Joseph Elmo Hall Memorial Lecture on Cervical Cancer. This morning's conference is hosted by the Jamaica Cancer Society with distinguished panelists, including Dr. Natalie Medley Singh, Dr. Troy Gadcliffe, Dr. Jody Taylor, Dr. Leslie Mead, Dr. Jordan Hardy, as well as Dr. Dingo Spence. Of note, we have a dedicated Q&A section for questions which will be answered at the end of each session. I will now hand you over to Mr. Earl Jarrett, who will welcome you and provide the opening remarks.
Thank you so much, Dr. Jessica Henry. Was consented and volunteered to be our moderator this morning. Dr. Henry is an obstetrician and gynecologist from the Cornwall Regional Hospital. I'd also just like to mention members on the first panel. Dr. Natalie Singh from the University Hospital of the West Indies and the Moon Institute of Medical Sciences, Dr. Troy Gatliff from the Miami Cancer Institute of Baptist Health, South Florida, Mr. Michael Leslie and Mrs. Julianne Brown, both of the Jamaica Cancer Society, both leaders in the Jamaica Cancer Society, members from the medical fraternity who have taken the time to be with us this morning. I'd also just like to make special welcome to Dr. Wendell Guthrie, who I see is in the audience this morning. He should normally, or would normally be on this side of the fence, providing a lecture to us on an area that he's an expert in. Welcome, Wendell Guthrie. I'd also just like to mention our sponsors, the Miami Cancer Institute of Baptist Health, South Florida, and the Jane Life Insurance Company. Just wanted, particularly make special recognition of them, and that through their efforts, we're able to provide this symposium and also to ensure the sustainability of the Cancer Society and our achievement of our mission. So with that said, I'd just like to welcome you all. But just to give us a sense of background as to why we're here. Today we reflect on the professional life of Dr. Joseph St. Elmo Hall. Dr. Hall was among the first batch of students in 1948 in the newly created University of the West Indies, which then had only one faculty, which was the Faculty of Medicine. The university, as you know, was created out of the Moyne Commission report that indicated that there was a need for a university in the Caribbean, and Mona was the first site of it. And Dr. Hall was one of those first students who joined the university as a student. Dr. Hall then traveled abroad to the UK, where he continued to study medicine and returned to Jamaica as an obstetrician and gynecologist. He returned in the 1960s and immediately took up a career at the University of the West Indies as a lecturer, and also started a private practice then. In those early days, he immediately became a member of the Jamaica Cancer Society. And over the many years, he rose within the Cancer Society's ranks, being a dedicated volunteer. He also became a director, head of the medical clinic committee, and was a constant champion for the cause of women's health and in particular, gynecological health. Dr. Hall was an innovator. He introduced the use of the colposcopy in the island, and many years later, through a grant from PAHO, introduced it across the Caribbean. He was a man who sought to make a difference, and he did achieve that at the Jamaica Cancer Society and across the Caribbean space as well. Dr. Hall was deeply committed to improving the condition of women and the people of Jamaica. And he not only offered his medical and professional help in that cause, but he was also an advocate for women's health through providing greater access to gynecological services. And his core objective was to reduce the burden of cervical cancer on the population of Jamaica. At the time in the 1950s, 1960s, Jamaica had a relatively high incidence rate for cervical cancer. And he, recognizing that cervical cancer did not have to be a death sentence, recognized the need to increase the level of screening in the island. And he ensured that access to the simple pap test was made available through the Cancer Society to the people of Jamaica. But he also recognized that a lot of the work has to do with education and training. And so through his efforts, he began a campaign to bring the knowledge of screening to the population of women in Jamaica by attending and hosting many sessions across the island in churches and schools where women gathered to hear from him and others on the ways in which you can reduce the burden of cervical cancer. Dr. Hall was not just an advocate for teaching persons, but he also influenced the government when he could. And he was able to convince the government to improve its resources towards the fight against cervical cancer. Dr. Hall was also a great fundraiser, not just raising his own funds from the public, but even his own funds were put into the cause. And one can recall Dr. Hall pulling together the influences of the time, great Jamaican women, including then Prime Minister of Jamaica, Portia Simpson Miller, then reggae artists and others, to have a campaign to promote the good benefits of pap smear and early screening. And through those influences, in that single year, we had an increasing number of women approaching the Cancer Society and clinics to be screened for cervical cancer. Dr. Hall not just was an advocate, not just was a fundraiser, not just was able to create a network of persons in the cause for cervical cancer, but in his own way, he too provided medical care for many persons who could not afford it. So the physician also came out in Dr. Hall, where at the Cancer Society, he staged many clinics himself, and in his own private practice, sought to also provide the care when patients couldn't afford it. I should also add that not only was he a physician, but the teacher in Dr. Hall came out in his daily life at the University of the West Indies, but also at the Cancer Society and nurses across the country, where he encouraged nurses to be able to do the pap smear, working with some of his students like Dr. Guthrie. He was able to help a lot of nurses to provide or to do the pap smears and to treat with the patients, to encourage persons and to reduce the fear that people have in going to the doctor. So this man was a true hero. He was a personal friend of mine. I enjoyed the years working with him, the years when we would leave Kingston and travel across the island to as far away as Westmoreland on one occasion, returning at 1 a.m. in the mornings. Dr. Hall did not drive a car. He preferred to drive a van that he could carry the material that he needed, television sets, tables, to go across the island to help women to make the wise choice and to reduce the burden of cancer. Today, we celebrate his life and work and recognize him as a hero of the Jamaica Cancer Society and also a hero in Jamaica and the Caribbean. To Dr. Hall's memory, I welcome you all to this medical symposium and lecture on cervical cancer. I should add as well too, that I'm happy to see Dr. Troy Gatcliffe and all the other presenters, but in particular, Dr. Gatcliffe and the Baptist Hospital, have been supporters of our cause for many, many years, and so have many of you, but I cite him because he's coming to us today from the United States, but normally he would be actually flying here. He's a Trinidadian by birth, so he's a Caribbean man, and we welcome him. And Dr. Gatcliffe, I had I don't know if you should call it a privilege or otherwise, but I was also a patient at the Baptist Hospital and at University Hospital. And I must say, the care that I received was second to none in both institutions. So with that said, I welcome you all and hope that you have a very meaningful day today. Thank you so much, moderator.
Life is full of twists and turns, slips and falls, and times of change. JN Life Insurance Company is here to help you with individual and family critical illness and whole life insurance plans to cover you and your loved ones when things change. So let's hold a reasoning. Let's talk life. Call JN Life at 876-926-1344 or 876-733-7130. JN Life, we'll help you find a way.
All right, thank you, Mr. Jarrett. I'd now like to introduce our first speaker for today, who is Dr. Natalie Medlicine, who will be presenting on HPV testing and the WHO Cervical Cancer Initiative, highlighting in particular the implications for Jamaica. Just a brief background on Dr. Natalie Medley-Singh. Dr. Medley-Singh is currently a consultant obstetrician and gynecologist and gynecologic oncologist at the University Hospital of the West Indies, as well as the Faculty of Medical Sciences, Mona. Dr. Medley-Singh obtained both her MBBS as well as her DM in obstetrics and gynecology degrees at the University of the West Indies. She is a fellow of the American College of Obstetricians and Gynecologists, as well as an associate of the Royal College of Obstetricians and Gynecologists. Dr. Medley-Singh completed a fellowship in minimal access surgery from the World Association of Laparoscopic Surgeons in February 2019. In November 2019, Dr. Medley-Singh successfully completed the European Society of Gynecologic Oncology examination in Athens, Greece. In December 2020, she also completed the University of the West Indies Fellowship in Gynecologic Oncology. Currently, she works as both a consultant obstetrician and gynecologist, as well as a gynecologic oncologist at the University Hospital of the West Indies. She's very passionate about HPV testing and its implications, as well as the protocol and management development and implications in both the private and the public health sector in Jamaica. Please help me welcome Dr. Medley-Singh. Thank you.
Good morning, everyone. I would like to thank the organizers of this symposium for inviting me to speak on this topic that I'm very passionate about, as was mentioned. Allow me to share my screen. In May 2018, Dr. Ghebreyesus, the Director General of the World Health Organization, issued a call to action for the elimination of cervical cancer. He stated, "We have the knowledge and the tools to stop women from suffering and dying from this preventable disease." Soon after this, a WHO global strategy to accelerate the elimination of cervical cancer as a public health problem was presented and unanimously endorsed at the 73rd World Health Assembly in August 2020. And subsequently, the WHO officially launched the global strategy to accelerate the elimination of cervical cancer in November 2020. And cervical cancer is indeed preventable. So this is the first global health strategy for the elimination of cervical cancer as a public health problem. Achieving and maintaining the 90-70-90 targets by 2030 would result in over 62 million cervical cancer deaths averted by 2120. So what are these targets? First, 90% of girls should be fully vaccinated with the HPV vaccine by age 15 years, 70% of women screened with a high performance test by age 35 and again by 45 years of age, and 90% of women identified with cervical disease should receive treatment, and this includes both cancerous and precancerous lesions. To eliminate cervical cancer as a public health problem, all countries must work towards an incidence of below 4 per 100,000 woman years. And where are we currently? The chart here shows us the global average is 13.3 per 100,000. Here in the Caribbean, we're a little above that global average of 13.7 per 100,000. You can see though that some countries, for example, Western Asia, are already there at 4.1 per 100,000, but unfortunately, countries such as Eastern Africa receive very high incidence of about 40.1 per 100,000. Where are we in Jamaica? Looking at the age standardized rate from the period of review from 1993 to 2011, we can see that we have made dramatic improvements. So there's a significant reduction, starting from 25.2 in 1993 down to 15.7 in the last published period of review, 2008 to 2011. So let's look at each target, starting with vaccination. So vaccination of adolescent girls is the most effective long-term intervention for reducing the risk of developing cervical cancer. The HPV vaccination program in Jamaica started in 2017 as a school-based program with the 2 doses of the bivalent vaccine. So girls who are vaccinated from 9 to 14 will only need 2 doses. Persons 15 years and over would need the 3-dose schedule. So this was offered to girls in the grade 7 cohort. And approximately 20,000 to 22,000 girls were targeted each year based on the school population. So here we see how this program went. So starting in 2017, just under 3,000 girls received the first dose. No one received the second or third dose. 2018, we see an improvement to about 6,000 receiving the first dose and approximately half that number receiving 2 doses. And the numbers improved even further in 2019, where just under 7,000 girls received the first 1 dose and about 6,000 receiving 2 doses. The numbers fell off significantly in 2020, about 500, and we see a further decline in 2021 and so far in 2022. And a lot of this could be due to the COVID pandemic. So these challenges with vaccination aren't unique to Jamaica, as globally HPV vaccine coverage is inequitably distributed, where higher income countries achieve higher vaccination coverage. As a matter of fact, between 2006, when the vaccine was first licensed, and 2017, more than 100 million adolescent girls worldwide received at least 1 dose of the vaccine. 95% of these girls, however, are in high-income countries. And this chart showing countries with a national vaccination program for HPV, we can see that almost 90% of high-income countries have an established vaccination program, but just over 20% of low-income countries have a vaccination program. This now brings us to treatment. 90% of women identified with cervical disease should receive treatment. Dr. Christopher Tufton, in a statement to Parliament in October 2017, stated that here in Jamaica, it's estimated to cost $274.4 million to treat approximately 392 cases every year. And this figure is only for radiotherapy. It does not include diagnosis and chemotherapy. It does not include surgical treatment or palliative care. It also does not include the loss of productivity, as many of these are young women who are affected and are no longer able to be productive members of the workforce and may not be able to provide for themselves and their families. And this brings us to screening, which is where I believe a lot of the focus and attention needs to be placed. And at the target again, 70% of women screened with a high performance test by age 35 years of age, and again at 45 years of age. Dr. Ghebreyesus stated, because of its high level of performance, countries should ideally transition to HPV testing as a primary method of screening for cervical cancer. And the biological evidence linking HPV infections to cervical cancer is undeniable. We know that HPV DNA is detected in 99.7% of cervical neoplasia, both squamous and adenocarcinomas. Fortunately, most genital HPV infections are asymptomatic and declare within 1 to 2 years when immune function is normal. So it's these persisting or transforming HPV infections that go on to produce cervical cancer. So now a quick reminder of HPV. There are over 200 HPV subtypes divided into species and genera. All the cancer-causing or oncogenic strains are found in the alpha genera seen here in pink. These subtypes, genera, species are differentiated based on the gene sequence in the L1 protein. Of these 200 subtypes, there are about 60 types which infect the anogenital region. And here we see the variant of the HPV, structure of HPV variant. We'll see late proteins denoted L1, L2, and we have early proteins. I wanted to highlight these 2 proteins, E6 and E7, as these are the oncogenic types. These are the cancer-causing proteins of the HPV. E6 inhibiting tumor suppressor protein, P53, and E7 inhibiting retinoblastoma protein. There are 12 high-risk types of HPVs. Of all the HPV types, there are 12 types which are strongly correlated and classified as class 1 carcinogens according to the International Agency for Research on Cancer. And these are shown here. Of all these types, types 16 and 18 account for 70% of cervical cancers and the precancerous lesions, with type 16 accounting for 50% of these and 20% due to type 18. There are other types which have a weak association with cancer and are classified as class 2 carcinogens. I highlighted 66 and 68 as these are included in most, if not all, HPV tests, making up to 14 high-risk tests covered in HPV testing. So why should we transition to HPV testing? We know that cervical cytology traditional pap smears work. So why should we even consider HPV testing? As a matter of fact, in the United States, since they introduced cervical cytology in a screening program in the 1950s, they have seen a 60% reduction in cervical cancer incidence and deaths. Cervical cancer screening, however, yields the best results when it's introduced as a population-based screening program with a call and recall system. And the most developing countries face many challenges in implementing such programs. And this is mainly due to the cost of implementing such programs. So for example, we need doctors or nurses to collect the samples, technicians to process and interpret the reports, pathologists to confirm the reports, and of course, effective follow-up, especially for women with abnormal results so they can be treated appropriately. Also, there are limitations of pap smears. The false positive rate ranging from 6 to 25%, with a sensitivity of about 51%, and in terms of detecting high-grade lesion, the sensitivity varies from 20 to 70%. The specificity is good, however, at 98%. So because of this, more frequent testing is required with pap smears to overcome these limitations. Also, the pap smear or cytology may miss adenocarcinomas, which may be usually found in the canal, in the endocervical canal. And many may argue that there's liquid-based testing, which should be better than the traditional pap smears. However, the studies have shown that liquid-based cytology versus traditional pap smears have the same sensitivity, same detection rate for cervical cancer and precancerous lesions. The HPV testing offers superior sensitivity and reproducibility. HPV-based screening provides a 60 to 70% greater protection against invasive cervical cancer when compared to cytology. So women who test negative only need to be retested after a minimum interval of 5 years. So this will fit perfectly in a resource-limiting setting, as screening would only need to be done 5 yearly. In less developed regions, use of 1 or 2 HPV DNA tests in a woman's lifetime would be sufficient to make a major impact on mortality. And with the availability of rapid test kits, those testing positive can immediately be treated. And those testing negative will know that they're at a low risk of cancer for at least 10 years. HPV testing isn't without its limitations, however. Due to the low specificity of the test, without suitable triage algorithms, we may see increased referrals to colposcopy. And this may cause unnecessary anxiety, especially for women who turn out not to have any cervical disease. So a woman can test positive for high-risk HPV and not have any abnormal cells seen on her pap smear or a colposcopy. This woman, however, is still at increased risk and still requires closer follow-up, but the information is still useful. The WHO suggests using a HPV DNA primary screening either with or without triage in the cervical cancer screening program. So looking at this screen, triage, and treat approach, in which HPV testing is a primary screening, then these are the options for triage. 1, partial genotyping for HPV 16 and 18. So as discussed earlier, HPV 16 and 18 accounts for more or most of the cancers. So these are the most oncogenic strains. If a woman is positive for HPV and is found to be positive specifically for HPV 16 and or 18, then she may warrant more immediate treatment versus someone who is positive for HPV, but it's not 16 or 18, who may be followed up closely. Cytology, so someone with a positive HPV test could have a pap smear done to determine if she would need further intervention. Colposcopy, so they can be referred directly to colposcopy, but treatment will be determined based on the colposcopic impression. And then visual inspection with acetic acid or VIA. So VIA isn't recommended by the WHO as a primary screening modality because of low sensitivities and inter-observer variations. However, if the woman has a positive HPV test, VIA may be used as a triage tool in places where colposcopy or HPV genotyping isn't available. Other triage markers include markers of proliferative lesions such as P16 or MRI coding for viral E6 and E7. And this is on the premise that not all HPV infections go on to produce cancerous changes, but there are some markers of infections that you can use to determine which one of these infections might clear or which infection may progress to cancer. So looking at HPV genotyping, and we can see, well, this table here shows some of the commonly used or some of the available HPV tests on the market, starting with the hybrid Capture-2, which was the first to be FDA approved. The sensitivity is about 98%. It gives a qualitative report for HPV testing, but so it's unable to give a detailed report on the types of HPV. So it isn't able to do HPV genotyping for 16 and or 18. Then there's a care HPV sensitivity of about 90%, and it also doesn't do HPV 16 or 18 genotyping. The Cervista itself has 100% sensitivity, and the Cervista 16-18 does do genotyping specifically for 16 and 18. The Cobas and Abbott, these detect 14 high-risk types of HPV, and they're also able to do HPV 16-18 genotype. Jumping to the Expert HPV, which has 100% sensitivity, and it's able to do genotyping for 16-18. And what's great about this is that the results are ready within 1 hour, and we'll talk a bit more about this in rapid testing. So what's available to us here in Jamaica? Prior to January 2022, an HPV report, a positive report for a patient might look something like this, in which the patient, in this case, was positive for HPV category A9. So we know that she had HPV from this group here, either 16, 31, 33, 35, 52, or 58, but we wouldn't be able to tell exactly which type or types of HPV she was positive for. And this is just to remind you of what these categories are about. So A9, looking at the alpha genre, we see A9, we find 16, 31, 35, A7, 45, 18, and so on. So this is how the result was reported in batches. But since January 2022, what is great is that we now have genotyping for not only 16, 18, but we also have type 45, which is very common in our setting. So in this case, this patient is positive for HPV, but it was not, at least we know that it's not 45, 18, or 16. So it will be one of the other 11 high-risk types from the group here. Now looking at expression of E6 and E7 oncoproteins as a triage measure. So the detection of E6, E7 oncoproteins represent an attractive disease-specific marker of HPV oncogenic activity, as mentioned earlier. As I mentioned, the E6 and E7 play a pivotal role in starting the cascade of events leading to carcinogenic transformation by inactivating retinoblastoma and tumor suppressor proteins. So these can differentiate between the transient, non-significant HPV infections from those persisting and transforming infections. So one such test on the market is the OncoE6 cervical test. It's a commercially available test which detects E6 oncoproteins. It works through high affinity monoclonal antibodies for the E6 of HPV 16 and 18, and these are incubated with cervical cells. If the E6 oncoprotein is overexpressed, it binds to the monoclonal antibodies, and the complex is captured and developed in a nitrocellulose strip. And what is good is that it can be performed in less than 3 hours. And looking at biomarkers, other biomarkers for transforming HPV infections, we have P16, which is a cellular tumor suppressor protein, and it's a marker for transforming HPV infections. So the E7 oncogene induces P16 transcription, causes accumulation of P16 within the cells. A combined stain for not just P16, but also the proliferation marker P67 can help to highlight transformed cells. And the sensitivities and specificities are seen here, and it's more specific than HPV testing overall. What are some additional advantages of HPV testing? Self-sampling, rapid testing, and urine testing are also possibilities. So let's take a look at these. So the ability to screen oneself for cervical cancer is an attractive option to many. This can potentially overcome many practical and personal barriers to screening. There are several studies comparing self-sampling to clinician sampling. In one such study, comparing self-sampling kits being mailed out versus persons being invited to come in to be screened by a clinician, the participation rate was 23.6% in favor versus 12.6% in favor of self-sampling. Another study in Mexico, using self-sampling versus invitations to be screened by a clinician, found that the 98% participation rate for self-sampling versus 89% for those who opted to be screened by a clinician. And in Argentina, we can see 86% versus 20% in a similar study in favor of HPV self-sampling. But how effective, how reliable, how effective is HPV self-sampling? The earlier studies comparing self with clinician-collected samples suggested a 10 to 19% decrease in the sensitivity for detecting high-grade lesions. More recent data, however, has found that the accuracy of high-risk HPV DNA testing on a self-collected sample is similar to that of clinician-collected samples if a validated PCR test is used. And what is also great is that self-sampling is supported by the World Health Organization. And this brings us to rapid testing. CARE HPV is one such test, can give results within 3 hours and requires basic laboratory support. In a study in China comparing CARE HPV to the standard hybrid capture tool in detecting CRN3 or more, when comparing self-collected samples to clinician-collected samples, found that the sensitivity was 97% for both for clinician-collected samples, and for self-collected samples, the sensitivity of CARE HPV was 83.8% versus 90.2% for hybrid capture. The Expert HPV is also a rapid test that gives results in 1 hour. Advantages of this over the CARE HPV is that it's able to do genotyping for 16, 18, and or 45, and we stated already the importance of having this information, and it detects the remaining HPV types collectively. The test platform can also be used for tests such as HIV and other STD detections. So you can imagine a patient comes to clinic in the morning, and within an hour, right, she's screened for HPV, HIV, and STDs. The main limitation of this test, however, is the cost. And looking at urine sampling, the high sensitivity of HPV testing may allow the use of samples containing very low levels of HPV DNA like urine to be used for screening. Studies have shown a pool sensitivity of about 77%, the range from 50 to 98%. The specificity is about 94% with a wide range, 17 to 99%. The wider range in individual studies really highlights the heterogeneity of this testing modality. So as it is currently, HPV detection in urine may be feasible. However, further optimization and standardization of the methods used from sample collection to HPV testing is needed in order to recommend its widespread use. So how do we go about selecting an HPV test for cervical cancer screening with all this information available to us? Well, of course, the selection needs to be based on the clinical validation of the test, the manufacturer's requirements, cost of the test, cost of equipment and supplies, what HPV types are detected by the test, how are the results presented, is it by type or is positive or negative results? And we stated the importance of being able to do genotyping for different HPV types. What is the appropriate lot size to process the samples? Can it process samples individually or does it require a certain batch of 60 or 90? How long does specimen processing take? We spoke about the importance of having rapid testing available. What type of training is needed to process the results? What in-country support is available for equipment, installation, and maintenance? How is the quality of the test result controlled? Can self-sampling be used with the test? What are the requirements for storage and other supply chain management issues? And with the local distributor of the test, are there any conditions, arrangements, and additional costs to consider? So on the note of cost, I decided to go back to my first love of mathematics in doing this presentation and crunch some numbers. So looking again at the target of 70% of women screened by age 35 and again at 45, I determined the number of 35-year-olds in Jamaica using information from Statin, from the last census that was done. And I determined that there are about 19,000 35-year-olds. Achieving the minimum target of 70%, that would be about 13,500 35-year-olds. And using the cost of HPV testing in the private sector now of 10,500, this is a total of $142,750,000. And to screen them again in 10 years' time at the same cost brings us to $285,500,000. It is a costly venture, but we should recall that we are currently spending $274.4 million for radiotherapy treatment alone every year, bringing us to $2.7 billion in 10 years. This is 10 times more than $285 million in trying to play catch up with treatment. So I was very excited to see what's happening in our Caribbean neighbor, Antigua and Barbuda, where in March 2020, PAHO, in collaboration with the Basic Health International, started convening a training program for the implementation of the HPV test. At the end of the training phase, the implementation will follow, for which PAHO is providing support with the purchase of equipment and reagents to carry out the test. This is very exciting news. And one of my good friends and colleague, Dr. Cervical, is an instrumental part of this initiative. So in closing, I'd like to end with some more wise words from Dr. Ghebreyesus, which states the success of the drive to eliminate cervical cancer depends on political will, controlled action, investments, global solidarity, and importantly, sustainable and adaptable partnerships. So interventions and partnerships are definitely needed for us to be able to achieve the WHO 2030 targets. On that note, I'd like to thank you for your attention.
Okay, thank you very much, Dr. Medley, for that most informative presentation. Everyone, please note that we have a dedicated Q&A section for questions, which will be taken at the end of the session. I'd now like to introduce our next speaker for this morning session, who is also our guest speaker, Dr. Troy Gadcliffe, MD, gynecologic oncologist at the Miami Cancer Institute and the Florida Baptist Cancer Center. Dr. Troy Gadcliffe, MD, is part of the gynecologic oncology team at Miami Cancer Institute at Baptist Health, South Florida. He earned his medical degree from the Royal College of Surgeons in Dublin, Ireland, and completed an internship and residency in obstetrics and gynecology at the Boston University Medical Center in Boston, Massachusetts. Dr. Gadcliffe then joined the faculty at the University of Texas Southwestern Medical School and Parkland Hospital in Dallas as an assistant professor, teaching in the largest obstetrics and gynecology training program in the country and earning a National Faculty Teaching Award. He completed a fellowship in gynecologic oncology at the University of California, Irvine Medical Center in Orange County, California, where his research interests included molecular signaling pathways in ovarian cancer and chemotherapy in cervical cancer. Dr. Gadcliffe is board certified in obstetrics and gynecology and is a fellow of the American College of Obstetricians and Gynecologists and the American College of Surgeons. He offers minimally invasive surgical techniques, including robotic surgery, for all complex gynecologic and women's reproductive cancer diagnoses. He has a strong personal and professional interest in caring for patients from the Caribbean and Latin America. He has also lectured throughout the West Indies and worked with public and private sector physicians in several countries to raise the standard of healthcare for women with gynecologic cancers. Dr. Gadcliffe was born and raised in Trinidad and Tobago. Everyone, please help me welcome Dr. Troy Gadcliffe.
Good morning. Thank you to the Jamaican Cancer Society for inviting me to once again present at the Dr. Joseph St. Elmo Hall Memorial Lecture. It is my pleasure to be here again to speak with you today. My name is Dr. Troy Gadcliffe, and I am a gynecologic oncologist at the Miami Cancer Institute, Baptist Health, South Florida, and I'm speaking to you pre-recorded from my office here at the Institute just a few days before the Sunday that you will be seeing this. Thank you all for inviting me, and I'll just get right into my discussion today, which is about advances in vulvar cancer treatment. So I'm going to go ahead and share my screen with you, and you will see the slides come up. All right. Today we're going to discuss advances in vulvar cancer treatment. In terms of vulvar anatomy, the vulva is the female external genitalia, which include the labia majora, labia minora, clitoris, vestibule, the vaginal introitus, as well as the urethral meatus, and also importantly, the Bartholin gland complexes at 5 and 7 o'clock at the bottom of the posterior fourchette of the vulva. Vulvar anatomy would be familiar to all of you who are gynecologists. And since we are speaking among physicians and providers here today, I wanted to very briefly review the anatomy of the female external genitalia, since we are discussing vulvar cancer, most importantly, the labia majora and the labia minora. But there are multiple other structures involved in the external female genitalia, all of which can become involved with vulvar cancer. The clitoris as a midline structure and the prepuce of the clitoris are important, especially when considering surgical options, as these are important for sexual function. In addition, the presence of the urethral meatus within the vaginal introitus and the perineum are all important structures of the vulvar anatomy. It's important to know that the lymphatic drainage of the vulva is most importantly, firstly, to the superficial inguinal lymph nodes, and from there to the deep inguinal lymph nodes, and then from there to the iliac pelvic lymph nodes. However, midline structures such as the clitoris or the midline structures of the vulva within 2 centimeters of the midline can drain directly to the obturator or pelvic lymph nodes. And this will become important later on as we discuss how we access the sentinel lymph nodes of vulvar drainage. Importantly, there are both superficial and deep inguinal lymph nodes, either superficial to the cribriform fascia or deep to the cribriform fascia. And in the femoral triangle, most of us who are physicians and surgeons would know the old acronym of NAVY, which is nerve, artery, vein, empty space, and then the lymph nodes. So in the superficial cribriform fascia, the superficial inguinal lymph nodes can be found by opening the skin over the femoral triangle and locating the long saphenous vein. Of course, the lymph nodes are not readily apparent unless we do something to make them apparent, such as the injection of radioisotope colloid or blue dye. The lymph nodes are in fact just contained within the fat pad above the cribriform fascia to the side of the femoral artery and vein. The deep inguinal lymph nodes are deep to the cribriform fascia, and this is where the nerve, artery, vein, empty space, and lymph node acronym comes from. So working from lateral to medial, first you have the femoral nerve, subsequently the artery, then the femoral vein, and then there's an empty space before you arrive at the space where the deep inguinal lymph nodes are. And I stress the anatomy of the femoral triangle and the lymphatic drainage of the vulva, as this is a very, very important aspect of the management of vulvar cancers. And in fact, positivity of the femoral lymph nodes and the sentinel lymph nodes are probably the most important prognostic factor in the treatment of vulvar cancer. From the superficial and subsequently deep inguinal lymph nodes, the drainage then moves on to the pelvic lymph nodes, most importantly, the iliac and obturator lymph nodes. Once vulvar cancer has spread to these deeper lymph nodes, which are considered distant to the vulva, this would be an advanced stage of disease. Vulvar cancer is broken up into many different histologies. However, over 75% or close to 75% are squamous cell carcinomas. And this is the predominant, most common kind of vulvar cancer seen. Other histologies include melanoma, basal cell carcinoma, Bartholin gland adenocarcinoma, sarcoma, and Paget's disease. The majority of vulvar cancers are associated with human papillomavirus. And this is important as HPV is very, very common and ubiquitous, especially in younger age groups. However, you will see that vulvar cancer is indeed cancer that predominates in postmenopausal women. Secondly, and most importantly, vulvar dermatoses such as vulvar lichen sclerosis can be associated with an increased risk of vulvar cancer. In terms of the United States epidemiology, which is where I practice, I wanted to share with you some basic information about what we see here in the US, a country of 330 million people. There are approximately 6,500 or roughly about there new cases of vulvar cancer a year and approximately 1,500 deaths. So it is a relatively rare cancer, but an important one that we deal with as gynecologic oncologists. Women in the United States have a 0.3% lifetime risk of being diagnosed. So this is indeed a rare cancer, but an important one for us to keep on our radar. The average age of diagnosis in the United States is approximately 68 years of age. And as you can see from the age distribution breakdown at the bottom of the slide here, most of these cancers are diagnosed in the postmenopausal age group. This is very much a cancer of postmenopausal women. The etiology of vulvar cancer is proposed to be coming from two different possible pathways. The most common of which we think is the mucosal human papillomavirus infection pathway, but also chronic inflammatory processes of the skin of the vulva or autoimmune processes also contribute to the possible etiologies of vulvar cancer. So this is not completely HPV related, although we think that HPV is indeed a very, very large part of the etiology of vulvar cancer. For patients with vulvar dermatoses such as lichen sclerosis, differentiated vulvar intraepithelial neoplasia has been proposed as the precursor lesion to vulvar cancer. Differentiated VIN, which I'll get into in a slide or two more, is often found in lesions previously diagnosed as lichen sclerosis, which have progressed to vulvar cancer. Here's a picture of a vulvar lichen sclerosis patient along with concomitant vulvar squamous cell carcinoma, the area here showing a raised, well-demarcated reddened lesion along with the classical skin changes associated with vulvar lichen sclerosis. Lichen sclerosis has many different ways of presenting, and again here we see a well-demarcated lesion of a carcinoma in association with vulvar lichen sclerosis, one of the most common skin dermatoses associated with the vulva. Risk factors for vulvar cancer include vulvar or cervical intraepithelial neoplasia, a prior history of having a cervical cancer. Cigarette smoking is indeed an important risk factor for vulvar cancer, as are the dermatoses, which we've discussed previously, such as lichen sclerosis, immunodeficiency syndromes, and Northern European ancestry. In terms of the terminology that we're using for the precursor lesions, there have been multiple iterations, and the most common now used is the 2015 ISSVD terminology, which is prevailing at the current time, where we break vulvar intraepithelial neoplasia or the precursor lesion into two groups: low-grade or LSIL of the vulva and high-grade or HSIL of the vulva. Differentiated VIN is the form of the precursor lesion that is most commonly associated with a vulvar dermatosis, such as lichen sclerosis. The clinical presentation of vulvar cancer is most often symptomatic and asymptomatic, and most patients will present with no symptoms at all, but a lesion found at the time of exam. Some patients do present with vulvar itching or pruritus and maybe even bleeding. A lesion is most often present, most often in the labia majora, and it can involve all of the other various areas and structures of the external genitalia. Importantly, a synchronous second malignancy, most commonly cervical neoplasia or precancer of the cervix, is found in almost a quarter of patients with a vulvar malignancy, again due to the possible etiology of being associated with HPV. So it's important when we find a vulvar cancer to also determine that the patient's cervix is either normal or involved. The two most common presenting symptoms of vulvar pruritus, especially when there is an underlying dermatosis such as lichen sclerosis, and other presentations can include bleeding and pain. Again, vulvar cancer can involve multiple different areas. There's not one particular area, although the labia major is the most common place. But here we see a vulvar cancer involving the perineum, or the posterior fourchette of the vagina, the space between the bottom of the vagina and the anus. Here is a more fungating or exophytic lesion of an exophytic squamous cell carcinoma involving the clitoris and the midline structures, completely obliterating all of the normal anatomy in the anterior compartment of the external female genitalia. You can also have very ulcerated and fungating outward growing lesions that involve the vulva as well. In terms of histology, as I mentioned before, squamous cell carcinoma accounts for 3/4 or approximately 75% of vulvar malignancies. And there are two subtypes that are important here. There is the classic warty or boenoid type, which is predominantly associated with HPV, especially HPV 16, 18, and 33, and is more commonly found in younger patients. There is also the keratinizing differentiated or simplex type, which is more common in older patients and is often not related to HPV, but more associated with vulvar dermatoses and dystrophies such as lichen sclerosis. Other histologic types include melanoma, which in fact is the second most common vulvar cancer histology, verrucous carcinoma, basal cell carcinoma, sarcoma, Paget's disease of the vulva, and Bartholin's gland carcinoma. Here's a great picture of extensive Paget's disease of the vulva, also involving some areas of carcinoma. Paget's disease has a very distinctive appearance and can often be mistaken for vulvar carcinoma, but it's fairly easy to diagnose on biopsy. And these large Pagetoid cells are the telltale histologic hallmarks of Paget's disease, extramammary Paget's disease of the vulva. And on a higher magnification, these Pagetoid cells are very telltale to differentiate what may be a suspicious precursor lesion such as VIN from Paget's disease. And I'm not going to get too into Paget's disease, as the main focus of our talk today is on vulvar cancer or carcinoma. The mode of spread of vulvar cancer is typically by direct extension. That is, growth of the lesion directly into adjacent structures, such as the vagina, the urethra, the clitoris, or even into the anus. Importantly, as I alluded to before, lymphatic spread is the most important prognostic factor. And the lymphatic spread is first to the superficial inguinal lymph nodes and immediately to the lateral, immediately to the deep inguinal lymph nodes, and also from there, possibly to the pelvic lymph nodes. Hematogenous or spread via the bloodstream is also possible, and this typically occurs late in the course of the disease and is rare in patients without having inguinofemoral lymph node involvement first. Lymphatic spread, lesions that are on the side of the vulva, are generally spread into the ipsilateral inguinal groin nodes. Only midline structures within 2 centimeters may drain to either side, and approximately 10% of superficially invasive vulvar cancers, that is lesions with greater than 1 millimeter but less than 3 millimeters of depth of stromal invasion, actually have lymph node metastasis at the time of diagnosis. So lymph node involvement is an extraordinarily important prognostic indicator. Variables with the strongest association with lymph node metastasis is if the lesion shows lymphovascular space invasion on the biopsy, what stage the cancer is at the time of diagnosis, which I'm going to get to soon, and importantly, the depth of infiltration. And here, millimeters actually matter. So I'm going to get a little bit into the staging and the pathology and the things that we look at for prognostic factors and how to stage vulvar cancer. The current staging involves a hybrid of both clinical and surgical approach, first introduced in 2009, and the current version was published in 2017. The shift away from solely clinical staging happened because clinical staging can miss up to 24% or a quarter of microscopic nodal metastases. That is, you can feel and palpate someone's inguinal lymph nodes, and they can feel palpably normal and non-enlarged, but there may be microscopic nodal spread at the time of diagnosis. Therefore, the system was combined to include not just the clinical staging, but also staging involving the checking of lymph nodes, particularly sentinel lymph nodes, which I'll get to in the full staging of vulvar cancer. Surgical assessment and treatment techniques involve both vulvar excision and lymphadenectomy, which have now evolved to allow for less extensive surgery. Clinical staging involves inspecting and measuring the actual lesion, tumor size, depth of invasion found by the pathologist once the tumor biopsy has been obtained, and local extension of the tumor is mostly determined by physical examination. Lymph node evaluation, which is the surgical staging, is evaluated obviously first by physical examination. Sometimes inguinal lymph nodes are palpably enlarged at the time of diagnosis, or by sentinel lymph node biopsy. The depth of invasion is determined most often by the pathologist at the time that the tumor biopsy is taken. And the depth of invasion is taken from the deepest point of the tumor, measured from the most superficial, closest dermal papilla. So the depth of invasion is taken from the deepest point of the tumor to the most superficial point of the closest dermal papilla, and that is the actual measurement in millimeters of the depth of invasion. So again, the tumor is measured by the pathologist, and here, as you can see on the slide, this would be the most superficial dermal papilla here, and this is the deepest portion of the tumor here. This would be the entire depth of invasion, and millimeters actually matter, as we'll see when we discuss some of the management strategies. Imaging studies are used to help with clinical staging. Tumor size often is not completely apparent just on physical exam, as deeper portions of the tumor may involve other structures and involve deeper portions of the nearby areas of the vulva. And therefore, we do use MRI and other imaging modalities to help us understand what may be involved. In addition, sometimes physical examination in the awake patient in the clinic may be too painful and necessitate an exam under anesthesia. Pelvic lymph node metastasis, if there are palpable pelvic lymph nodes at the time of diagnosis, this would completely change the stage and upstage the patient. But if there is a suspicion of advanced disease, obtaining imaging studies to see if they are distant metastases, such as liver or lung metastases, are really important. Imaging is also used, as I mentioned previously, to determine whether there are tumors of a certain size, with 4 centimeters being an important cutoff, and whether there are clinically palpable inguinofemoral lymph nodes or lymph nodes that may be involved that are not clinically palpable. So tumor extent is sometimes often easy to see if there's a large external lesion, but the tumor size may not be fully or readily apparent, and sometimes we do use imaging to get an idea of the full extent of the disease. Here we have on an MRI a truly palpable enlarged inguinal lymph node that just on physical examination would be readily palpable, but sometimes in larger or more obese patients, an enlarged lymph node which would be palpable in a thinner patient may not be readily apparent, and therefore we do use imaging to look at the size of the inguinal lymph nodes. In terms of the staging, stage 1 tumors are broken down into stage 1A and 1B. 1A tumors are tumors of less than 2 centimeters in size, but are confined to the vulva or perineum with stromal invasion of 1 millimeter or less. If there is invasion of more than 1 millimeter or lesions are more than 2 centimeters in size, that is a 1B tumor. Stage 2 tumors involve extension to adjacent structures, such as the lower distal third of the urethra, the lower distal third of the vagina, or any anal involvement. Stage 3 tumors, which we'll get to shortly, are all of the different subclassifications involving lymph node metastases, and stage 4A tumors involve extension into the upper proximal or 2/3 of the urethra, vagina, bladder mucosa or rectal mucosa, or whether the tumor is fixed to the pelvic bone. As I said before, the various stages involving stage 3 have to do with positive lymph node involvement. And here again, millimeters matter. And the number of involved lymph nodes, whether there are 1 or 2 lymph nodes involved with metastasis, each less than 5 millimeters in size or more than 5 millimeters in size changes the various stages of stage 3. Again, remembering that midline structures that are close to the midline within 2 centimeters have the propensity not only to drain to ipsilateral lymph nodes, but can also drain to contralateral lymph nodes. And that's an important cutoff for us to remember. Superficial inguinal lymph node or deep inguinal lymph node involvement can involve stage 3A and stage 4A tumors, whereas pelvic lymph node involvement upstages the patient automatically to stage 4B, the most advanced stage. Treatment of vulvar cancer involves excision and assessment of the lymph nodes if they are not found to be obviously clinically enlarged or palpable. This can include radical vulvectomy of the anterior hemivulva, and a unilateral or lateral hemivulvectomy with clitoral sparing, or a posterior vulvectomy depending on the area of the lesion. Obviously, anterior hemivulvectomies with an involved clitoris would severely disfigure the patient and involve issues with sexual function with removal of the clitoris. Ipsilateral or lateral hemivulvectomy with clitoral sparing is a choice for a lateral lesion, and a central lesion posteriorly may involve a posterior hemivulvectomy. Inguinofemoral lymphadenectomy is now performed using separate incisions, whereas we have evolved from using large incisions with both sets of lymph nodes assessed. Now we're using even smaller and smaller incisions, and now we have evolved in the last few decades to where we are solely assessing sentinel lymph nodes in clinically uninvolved lymph nodes. This is what we used to be dealing with years ago when we would be doing full lymphadenectomies. We would have patients with lower extremity lymphedema. Lower extremity lymphedema is a serious complication of removing the inguinofemoral lymph nodes, as you would see in the upper extremity with full axillary lymphadenectomy for patients with breast cancer. And this is why we have evolved to looking at sentinel lymph nodes. The concept of sentinel lymph nodes is, of course, not by any means new at this point. Tumors will spread via lymphatic spread, first to a sentinel or gatekeeper lymph node, before spreading on to other lymph nodes in the chain distally. Finding and identifying the sentinel lymph node has been studied extensively in multiple forms of cancer, but was most originally looked at in breast cancer. Sentinel lymph node technology is now used in vulvar cancer, as well as cervical cancer, as well as endometrial cancer in gynecologic malignancies, and formal evaluation of the distribution of sentinel lymph nodes shows that 100% of sentinel lymph nodes lie over or medial to the femoral vessels in the femoral triangle. In one study that involved over 59 women with vulvar cancer less than 4 centimeters, The sentinel lymph nodes were superficial in approximately 85% of cases and not below the cribriform fascia, only with 15% of the lymph nodes deep to the cribriform fascia. These observations obviously have important implications for the extent of inguinofemoral lymphadenectomy, as well as the selection of radiotherapeutic targets and techniques. How are sentinel lymph nodes detected now? We inject ICG nanocolloid injection directly into the tumor. We use preoperative imaging to help us locate where the sentinel lymph nodes are. And then shortly before taking the patient to surgery, we'll additionally inject blue dye into the tumor as well. And with a combination of both preoperative ICG nanocolloid injection as well as blue dye injection, we'll be able, both with gamma tracing as well as fluorescence imaging, to locate the sentinel lymph node by inspection after opening the inguinofemoral triangle. The most important update on sentinel lymph node technology came from the Groins V2 GOG 270 study, which was recently published within the last year. The most important take-home message from this important clinical trial is listed here for you. The inguinofemoral radiotherapy is a safe alternative for inguinofemoral lymphadenectomy in patients with micrometastasis with minimal morbidity. The purpose of this study was really to figure out whether, when we looked at radiotherapy as a method for treating vulvar cancer metastatic to the inguinofemoral lymph nodes, was it a safe alternative to look at inguinofemoral radiotherapy as a safe alternative in vulvar cancer in patients with metastatic sentinel lymph nodes. So for patients with macrometastases, radiotherapy with a total dose of 50 gray resulted in more isolated groin recurrences compared with inguinofemoral lymphadenectomy in total. This is an important study that has now guided how we find and use intraoperative sentinel lymph node positivity in patients with vulvar cancer. Eligibility for sentinel lymph node dissection or sentinel lymph node biopsy is importantly still evolving. And the issue regarding the risk of a groin recurrence in patients of tumors greater than 2 centimeters still requires further investigation. So among the experts in this field, most offer sentinel lymph node biopsy to a very select group of patients who meet the criteria of the Groins v. GOG 270 study, with a few additional criteria. These are all tumors that are small or less than 4 centimeters in size. They all have a depth of invasion of over 1 millimeter depth of invasion. There are no palpable, obvious groin lymph nodes that are palpably involved, and the disease on the vulva is unifocal. The surgeon has to have sufficient expertise to perform a sentinel lymph node biopsy, and most of the surgeons that do this have done this multiple times over and have performed at least 10 sentinel lymph node biopsies. However, a more conservative approach is reasonable and is used in some institutions, with sentinel lymph node biopsies offered only to patients with tumors that are less than 2 centimeters in diameter. In terms of the NCCN guidelines that we use here in the US, early stage disease, that is tumors that are T1 and small T2 tumors, are biopsied to figure out whether there is less than 1 millimeter of invasion or more than 1 millimeter of invasion. In terms of what can be done surgically, tumors that have less than 1 millimeter of invasion are offered simple partial vulvectomies. If the tumor is a 1B tumor with more than 1 millimeter of invasion, is a lateral lesion which is greater than 2 centimeters from the vulvar midline, a radical partial vulvectomy with ipsilateral inguinofemoral lymph node dissection or sentinel lymph node dissection is offered. And if there is a central lesion, it will include a radical partial vulvectomy, again with sentinel lymph node biopsy if feasible within that center. In terms of the lymph node positivity, if there is sentinel lymph nodes that are positive and there is a single positive sentinel lymph node with less than 2 millimeters of metastasis, the patient is then offered extended beam radiotherapy with concurrent cisplatin radiosensitizing chemotherapy. If there are positive sentinel lymph nodes with greater than 2 millimeters of metastasis, then a full, complete inguinofemoral lymphadenectomy is offered, or extended beam radiotherapy is offered. If there are locally advanced larger tumors, these patients are almost universally treated with radiation, as surgical resection and sentinel lymph node mapping does not provide a better option for treatment. Stage 1 tumors, the number of patients in this study, there was approximately a 96% survival with a 5-year survival of 78%. Stage 2 tumors that have spread to adjacent structures without spread to sentinel lymph nodes have approximately 60% 5-year overall survival, with the most important prognostic factor being stage 3 tumors that include positive lymph nodes in the inguinofemoral lymph node region with a 43% 5-year overall survival. Stage 4 patients have a relatively poor prognosis with an only 13% survival. Thank you for your attention. Thank you for allowing me to present. My email address is contained in this slide and I'm available to you for questions or to share the slides. Our country manager for the English-speaking Caribbean is hopefully known to many of you, Miss Kathleen Tuitt, who is our country manager that includes Jamaica. Her email address is kathleen.t@baptisthealth.net. My email address is tgatliff@baptisthealth.net. Importantly, if you wish to avail of our services, there is a 24-hour coordination of care line, which is listed here, or you can email Baptist Health at international@baptisthealth.net, or go to our website, baptisthealth.net/international, for more information on obtaining care within our institute. I want to thank you all for your attention today. Thank you again for allowing me to present on vulvar cancer. I wish you all a great conference. I know that in the lineup I saw great talks to come. Thank you for allowing us to be part of your event, and I look forward to seeing you all again soon. Thanks.
All right. Thank you so much, Dr. Gadcliffe, for a most researched and informative presentation. Of note, just before we move to our next presenter for this morning's session, I'd just like to remind the attendees that we have a dedicated Q&A section where you can post your questions related to the presentations. All questions will be answered at the end of this session. I'd now like to introduce our next presenter for this morning, Dr. Jody Taylor, consultant, oncologist, and hematologist at the Cornwall Regional Hospital. Dr. Taylor did her MBBS undergraduate degree as well as her Doctor of Medicine degree at the University of the West Indies, Mona. She currently works at the Cornwall Regional Hospital, where she has special interests in medical oncology. Ladies and gentlemen, please help me welcome Dr. Jody Taylor, who will present to us on systemic therapy for cervical cancer.
Dr. Taylor, can you please unmute?
Yes, I realized my mic was muted. Good morning, everyone. Thanks to the organizers of this symposium for inviting me to speak on cervical cancer, the systemic therapy management, and where we are now. I am going to share my screen. Okay, so cervical cancer is important because it's a global problem. It's the fourth most frequent cancer worldwide, according to figures from WHO, and it has a higher mortality rate in patients who are in middle and low income countries. Locally, it's the second most frequent cancer in women, especially in the 15 to 44 years age group. Staging is according to the FIGO staging system and largely is divided into stages 1, 2, 3, and 4, with stages 1 being carcinoma or cancer confined to the cervix, stages 2 being that invades beyond the uterus but has not extended onto the lower third of the vagina or to the pelvic wall. Stages 3, the cancer either involves the lower third of the vagina or extends the pelvic wall and/or causes hydronephrosis or non-functioning kidney, or there's involvement of the pelvic and/or para-aortic lymph nodes. Stage 4 is divided into stages 4A and 4B, with 4B being spread to distant organs and stages 4A being that of involvement of the mucosa of the bladder or the rectum. This is just a pictorial, again, representation of the stages. And it also shows that as the stage increases, then the 5-year survival decreases. Current treatment options for cervical cancer can be divided into surgical and non-surgical approaches. Of course, the surgical approach would be discussed by the surgeons, and my focus will be on what I am trained in, non-surgical approaches, specifically systemic therapy, whether it is chemotherapy or targeted therapy. So factors determining treatment choice include the stage of the cancer. That's the most important factor that we use. And for patients who are treated with hysterectomy, the presence of lymphovascular space invasion, parametrial involvement, or lymph node involvement are some of the criteria that the surgeons would apply to the patient's case to determine if they need post-surgical radiotherapy plus or minus chemotherapy. Stage grouping in terms of in the literature can divide the patients into those having early stage disease, which some articles showed it to be stages 1 or and 2A, and some limited to actually the stages 1A1 to 1B1 patients. For locally advanced disease, FIGO stages 1B2 to B3, 2B to 4A, or in some articles, any stage greater than or equal to 1B2 would be considered locally advanced. And as mentioned before, stage 4B, where there's distant organ involvement, is what we consider to be metastatic disease. So in terms of how we manage or treat locally advanced cervical cancer, 1999 was a pivotal year for the management of locally advanced cervical cancer. And this was because the National Cancer Institute mailed an announcement, something that it has only done on 4 occasions prior to this announcement, saying that for patients who require radiation therapy for cervical cancer, that cisplatin-based chemotherapy should also be incorporated into the treatment. This was done on the basis of 5 randomized controlled trials, which showed an overall survival advantage with concurrent cisplatin-based chemoradiation. And so the current standard of care is that of platinum-based concurrent chemoradiation. So the 5 landmark trials on which the NCI based its recommendation was that of the GOG 85 study, the RTOG 9001 study, GOG 120, the SWOG 8797 trial, and GOG 123. So with the GOG 85 study, it was essentially a randomized trial comparing 5-FU plus cisplatin as the chemotherapy agents used versus hydroxyurea as an adjunct to radiation therapy in patients with stages 2B to 3 to 4A carcinoma of the cervix who had negative para-aortic lymph nodes. So 368 patients were randomized, 177 to the cisplatin arm and 191 to the hydroxyurea arm. And the results showed that for patients who received the cisplatin-based chemoradiation, their progression-free survival and overall survival were statistically significantly better or superior to those who had received hydroxyurea as the chemosensitizing agent, the radiosensitizing agent. So this is just a graphical representation of the progression-free survival for the patients on this study. And it shows here that patients who received platinum-based chemoradiation had a better progression-free survival and also a more superior overall survival than the patients who had hydroxyurea as their chemotherapeutic agent. In the RTOG 9001 study, which looked at pelvic irradiation with concurrent chemotherapy versus pelvic and para-aortic irradiation for high-risk cervical cancer patients, these patients had stages 2B to 4A disease, stages 1B to 2A with a tumor diameter greater than or equal to 5 centimeters or positive pelvic lymph nodes. And these patients, again, in terms of long-term overall survival data, this was in favor of the chemoradiotherapy group, the platinum-based chemoradiotherapy group, where their overall survival was 67% as compared to 41% for patients who received radiation alone. This also was seen in terms of progression or disease-free survival, where the patients who had received chemoradiation also had a more superior disease-free survival. And again, this is just a graphical representation of that study where the concurrent chemoradiotherapy arm had a better overall survival than patients who had radiation therapy alone. And again, in terms of local regional recurrence, patients who had only radiation therapy had a higher risk of local regional recurrence or failure as compared to patients who received concurrent chemoradiotherapy. If by subgroups in terms of staging, patients, whether the patient had a stage 1 or a stage 4 disease, once they had concurrent chemoradiotherapy, their overall survival was superior. And as we can see, even within subgroups in terms of staging, patients obviously who had earlier stages, they did better than patients who had more advanced stage. The GOG 120 trial also looked at 3 arms in terms of chemotherapy arms. There was one arm that had single agent cisplatin, one that had cisplatin with hydroxyurea, or one that had hydroxyurea alone. And again, this study also showed that patients who had a platinum-containing arm, they actually had a better progression-free survival and overall survival compared to patients who did not have platinum-based chemotherapy. And again, this shows the superior progression, overall survival for patients who had cisplatin-based concurrent chemoradiation. And in terms of staging, stage 3 patients, again, treatment favored cisplatin-based chemoradiation. And for stages 2 patients, 2B, they also had a better overall survival if they received platinum-based chemoradiation. The SWOG trial looked at patients who concurrent chemotherapy and pelvic radiation therapy compared to just radiation therapy alone for patients who had high-risk early-stage cancer of the cervix. Patients had clinical stages 1A2, 1B, and 2A carcinoma of the cervix, and they were initially treated with radical hysterectomy and pelvic lymphadenectomy, and those who had positive pelvic lymph nodes or positive margins or microscopic involvement of the parametrium were eligible for the study. And again, this study was also in favor of concurrent chemoradiation therapy with a progression-free survival and overall survival favoring the concurrent chemoradiotherapy arm. And again, this is the progression-free survival for those who receive the concurrent chemoradiation therapy. And the last trial, the GOG-123 trial, look at cisplatin and radiation therapy, pre-hysterectomy, radical hysterectomy for patients who had bulky stage 1B cervical cancer. And so these patients were treated with either neoadjuvant chemoradiation or radiation only, and then went on to have hysterectomy. And again, the progression-free survival and the overall survival were both in favor of patients who had concurrent chemoradiation therapy. And so this here shows, again, the graphical representation of the superiority in terms of progression-free survival of the concurrent chemoradiation therapy arm as opposed to radiation therapy alone. And again, the overall survival was superior for those who had concurrent chemoradiation. So those 5 trials cemented concurrent chemoradiation therapy, as I said, the standard of care for patients who have locally advanced cervical cancer. So in terms of where we are now, concurrent chemoradiation therapy is the current recommendation for patients who have locally advanced disease. So as I was mentioning, platinum chemotherapeutic agents or drugs, I will briefly mention the more common platinum agent that we use as a radiosensitizer or the chemotherapeutic drug for patients who are receiving concurrent chemoradiation therapy. So this drug is cisplatin, as shown here, is the most commonly used drug in combination with radiotherapy for cervical cancer. It has a synergistic action with radiation therapy in that radiation therapy induces DNA damage with single and double-stranded breaks. And then the cisplatin also causes DNA damage. And essentially what will happen is that cells are unable to be, DNA is unable to be repaired, with resultant apoptosis. We usually administer the cisplatin on a weekly basis, once weekly, during the radiation therapy, and it is recommended that the administration be for at least 5 to 6 weeks. And this was based on, again, research that showed that for patients who had less than 5 weeks of chemotherapy, that their survival was inferior to those who had 5 or more weeks. Carboplatin is also another option that we use for patients who are intolerant of cisplatin. The mechanism of action is similar to cisplatin. So for locally advanced cervical cancer, that is where we are. Questions have been asked or posited as to whether we can improve on the outcome for patients with locally advanced cervical cancer. And this was the basis of the Outback trial to look at whether post-concurrent chemoradiation, should we give more chemotherapy? Should we administer adjuvant chemotherapy? And the findings did not support adjuvant chemotherapy after concurrent chemoradiation. That will go into the trial a little bit. So just to focus on the results of the trial. So patients essentially had cisplatin-based chemoradiation therapy, and then they were randomized to receive either 4 additional cycles of carboplatin and paclitaxel, or to not receive any further treatment. And in terms of primary endpoints, they looked at overall survival and also progression-free survival. And they found that overall survival at 5 years was not better or superior for the patients who had adjuvant chemotherapy. They're actually pretty similar, with a 72% overall survival for patients who had adjuvant chemotherapy versus 71% for patients who did not receive any adjuvant chemotherapy. The progression-free survival, there was not any difference really statistically, with those who received the adjuvant chemotherapy having a 63% progression-free survival versus 61%. So the conclusion, and this was one of the studies presented last year at different oncology meetings, was that adjuvant chemotherapy should not be given after standard cisplatin-based chemoradiation for women with locally advanced cervical cancer. So in terms of early stage cervical cancer, there's a question of whether you should recommend adjuvant therapy after radical hysterectomy. And this is all dependent on the stage and the surgical findings. So for patients who have early stage disease with negative lymph nodes who are found to have lymphovascular space invasion, deep stromal invasion, or large primary tumors, these patients should have postoperative radiation therapy plus or minus concurrent chemotherapy. Other high-risk findings after surgery, such as parametrial involvement, positive pelvic lymph nodes, positive surgical margins, these patients would require postoperative concurrent chemoradiation. Is there a role for neoadjuvant chemotherapy prior to surgery? Currently, it's not recommended by NCCN outside of a clinical trial, and that's because some studies have shown no overall survival benefit, while some have shown that neoadjuvant chemotherapy may be a strong prognostic factor for overall survival and progression-free survival. All right, so that's how we manage currently patients who have locally advanced cervical cancer. I mentioned towards the end some of the studies, ongoing studies that are looking to improve on management of locally advanced cervical cancer. Now I look at patients who have recurrent and metastatic disease, how we manage them currently. So this is from the current version of the NCCN guidelines, which shows that for patients who are PD-L1 positive in terms of their tumors, that the current recommendation is pembrolizumab, which is an immunotherapeutic drug, in addition to platinum-based chemotherapy, combination chemotherapy of cisplatin and paclitaxel, or carboplatin and paclitaxel. Bevacizumab, which is an anti-angiogenic agent, can also be added to the regimen. For patients who don't have PD-L1 positive tumors, then cisplatin with paclitaxel, both chemotherapeutic drugs, in addition to bevacizumab, which is an anti-angiogenic drug, or carboplatin taxol, are the current recommendations. There are other recommendations, including this chemotherapy alone, which is what we tend to use a lot in the public system due to these drugs, but pembrolizumab and bevacizumab being more so available only for private purchase, and they can be costly. In terms of second-line therapy, there are a number of single-agent chemotherapeutic drugs that can be used, and some newer drugs like this antibody drug conjugate. And for patients who have PD-L1 positive disease, tumors, or microsatellite instability high tumors, then immunotherapy agents such as pembrolizumab can be used. There's a note on bevacizumab, which is a vascular endothelial growth factor, a monoclonal antibody, binds all isoforms of VEGF-A. VEGF-A inactivation blocks signal transduction through the VEGF receptor 1 and VEGF receptor 2 associated pathways. Vascular endothelial growth factor is necessary for angiogenesis, which is tumor blood vessel formation. So tumor blood vessel formation, VEGF is a necessary agent. So the issue with tumor-related angiogenesis though is that it's disorganized. So it limits this drug delivery to tumor cells, and so by administering the bevacizumab, it is thought that there's more some regulation or more organization of the blood vessels, and then drug delivery, whether it is chemotherapy, etc., is better delivered to the tumor cells. It was approved for use in cervical cancer in 2014 based on the GOG 240 trial, which I will speak of now. So the GOG 240 trial showed that for patients who received bevacizumab in addition to chemotherapy, and the chemotherapy backbone was actually paclitaxel and cisplatin or topotecan. And it showed that for patients who received this anti-angiogenic agent, they had an overall survival benefit of 3.7 months. And they also noted that the response rate was also improved with the use of bevacizumab. The response rate was 48% for patients who received bevacizumab versus 36% for those who did not receive it. They also had final overall survival data that again show that long-term patients who received the bevacizumab actually had an improvement in their overall survival, 16.8 months versus 13.3 months, right? And again, the progression-free survival also favored the patients who received bevacizumab. As I mentioned before, bevacizumab is available locally. However, it is costly, and cost is a factor that comes into how we manage our patients. In terms of immunotherapy, it's essentially a new kid on the block for the field of oncology. A lot of exciting things happening with immunotherapy for both hematological cancers and solid tumors. So cervical cancer is no different. Immunotherapy, as I showed before, pembrolizumab is now recommended for patients who have, as first line, for patients who have PD-L1 positive tumors. So immune checkpoint proteins and signals regulate self-tolerance. What cancer cells do is that they would exploit checkpoint pathways in a bid to evade the immune system. Evading the immune system would mean that the immune system would not be able to, essentially remove the cancer cells. So on your T lymphocytes, the cytotoxic T lymphocytes, there's a PD programmed cell death 1 receptors. The tumor microenvironment also expresses programmed cell death 1 receptors, and cancer cells can actually express the ligands, programmed cell death ligand 1 and 2, which after binding to the programmed cell death receptors on the T lymphocytes will cause an off signal for apoptotic pathways. So by inhibiting whether PD-L1 or the PD-1 receptors, then we can allow the immune system to essentially work and for there to be cancer cell removal and death. So cervical cancer is a good candidate for immunotherapy because most of the cases are viral mediated, and there are other factors that we consider to be very immunogenic, such as the high tumor mutational burden, frequent neoantigen formation, and then you also have tumor infiltration by lymphocytes and macrophages. And as I mentioned before, that cancer cells can also amplify the production of checkpoint controlling targets, such as PD-L1. So pembrolizumab is a programmed cell death 1 monoclonal antibody or inhibitor, and it was approved, received accelerated approval for its use in cervical cancer. And since last year, it has now been approved as first line for patients who have PD-L1 positive tumors. And this was on the basis of the Keynote 826 trial, which showed that for patients who had a PD-L1 positive tumor, positive score of 1 or more, that their median progression-free survival was actually 10.4 months, as opposed to 8.2 months in the patients who received placebo. The overall survival at 24 months was also in favor of the pembrolizumab group, where 53% was noted in the investigational arm, as opposed to 41.7% in the control or placebo arm. So pembrolizumab is available locally. Again, it's one of those costly drugs. So in the public system, it may not be something that a lot of patients can afford, but we do recommend all these new agents to our patients. This drug, cemiplimab, is one of those newer immunotherapeutic drugs that everyone was waiting in 2022 here for it to receive FDA approval. And this was on the basis of the EMPOWER trial, which showed that there was an overall survival advantage with using the cemiplimab. Patients who had received it in addition to chemotherapy had overall survival of 12 months as opposed to those who did not receive the drug. Unfortunately, the company withdrew their application for FDA approval because I think they, according to their website, post-marketing recommendations, they were not able to come to an agreement with FDA, but they're seeking to use it in markets outside of the US. Now, chemotherapy is still a very relevant option for patients who have metastatic disease or recurrent cervical cancer. And as I've been mentioning, that is the main options that we have in our public system. Thankfully, the NHS makes cisplatin, carboplatin, paclitaxel. Those drugs are available for free for patients in the public system. So that at least is some light for us. So this study, the GOG 169 trial, looked at whether a combination of cisplatin with paclitaxel would be better than cisplatin by itself. And what it showed was that for patients who had a combination chemotherapy arm, that they had a higher response rate of 36% as compared to patients who had cisplatin alone. So you will see that we would recommend more so combination chemotherapy than single agent cisplatin for our patients. The GOG 179 trial looked at cisplatin plus topotecan versus cisplatin alone, and they also had a response rate of 27% in the combination arm as opposed to 13% in the single agent arm alone. And the progression-free survival and overall survival were both in favor of the combination chemotherapy arm. But the issue with topotecan, which is another chemotherapy drug, is that it has a greater toxicity than a paclitaxel cisplatin combination. So you will see that we tend to use a lot the taxane-based combination regimens. Topotecan can be sourced locally, but it is not available in the public system. The GOG 204 trial also looked at 4 combination chemotherapy regimens, and it was cisplatin with paclitaxel, cisplatin with vinorelbine, cisplatin with gemcitabine, and cisplatin with topotecan. And what it showed was that none of those other combination regimens were not superior to the cisplatin paclitaxel arm. In the JCOG 0505 trial, they looked at carboplatin Taxol versus cisplatin paclitaxel, which is again the recommended chemotherapeutic option. And what they showed was that the combination with paclitaxel and carboplatin was not inferior to that of the cisplatin paclitaxel. And so it is also an option that can be used, and we readily use it in treating our patients. So that essentially is what we have in terms of chemotherapy. And we also have some other single agent chemotherapeutic drugs that we can use in the second line setting. So a note on antibody drug conjugates, of which tisotumab vedotin is one such drug. It's an, as I said, antibody drug conjugate. It targets TC factor. It essentially has a monoclonal antibody attached by a linker to a cytotoxic payload. TC factor, we may remember, is important in terms of the coagulation pathway, but it has also been shown to be involved in oncogenesis and promoting tumor growth, survival, and metastases. TC factor is overexpressed in solid tumors, including cervical cancer. And so what investigators have done is that this antibody, tisotumab, it targets the tissue factor on the cancer cell. And then the cytotoxic portion, the vedotin, is released intracellularly, and it causes microtubule disruption, cell cycle arrest, and apoptosis. So this was a phase 2 study on which the tisotumab vedotin received FDA approval, and 102 patients were treated with this drug, and they had an objective response rate of 24% with 7% complete response and 17% partial response. As such, as I had shown, it is an option in terms of second-line therapy for patients who have recurrent or metastatic cervical cancer. In terms of what is also happening in terms of investigations or studies, as I mentioned before, even though the Outback trial did not, it was not a positive study for further chemotherapy drugs or adjuvant chemotherapy in the cervical, locally advanced cervical cancer population, there are studies now looking at combining immunotherapy with chemoradiotherapy for patients who have locally advanced cervical cancer. So durvalumab, pembrolizumab, atezolizumab, all these drugs are looking at whether or not adding immunotherapy to our current concurrent chemoradiation will improve on the patients with a progression-free survival and overall survival. So we await the results of those trials. Now, in patients who have recurrent or metastatic cervical cancer, there are also studies looking at combination of the bevacizumab, the anti-angiogenic agent, with other chemotherapeutic drugs, bevacizumab with here atezolizumab, which is an immunotherapeutic drug, and they also have combinations with multiple immunotherapeutic drugs. So again, that's what's happening for now for metastatic cervical cancer. There are also studies that are looking at using therapeutic vaccines or other antibody drug conjugates for patients with cervical cancer, and we await their results. So in summary, treatment of cervical cancer largely depends on the stage. Concurrent chemotherapy, chemoradiation therapy remains the standard of care for locally advanced disease. For patients with stage 4 or recurrent cervical cancer, the immunotherapeutic options and anti-angiogenic drugs that we have had added in the past decade or so have essentially been revolutionizing the treatment or management of these patients. And there are studies ongoing exploring adding immunotherapy to patients who are locally advanced and receiving concurrent chemoradiation therapy, and also for patients who have metastatic disease. Other options being studied are therapeutic vaccines and antibody drug conjugates. Thank you very much. These are some of my references. Back to the moderator.
All right, thank you so much, Dr. Taylor, for a most researched and informative presentation. We will now move to the Q&A segment. All right, we have a question here for Dr. Medley. The question asks, is there a time limit in which the second and third doses of the HPV vaccine should be taken once the first dose has been obtained? And the second part of that question asks, what are the hindrances currently in the call or recall system in Jamaica? Dr. Medley?
Okay, good morning again. Thank you for those questions. Okay, as it relates to the vaccine scheduling, there is no, what I would say, maximum time limit. So for those between 9 and 14 years of age who would get 2 doses, the second dose can be given anywhere from 6 to 12 months after the first dose. If this interval is missed, then the dose can be given immediately. So there is no need to restart the schedule or the program. And what is important to know is that there's a minimum interval of 5 months between the first and second dose. So the second dose is administered 5 months or less after the first dose, then a third dose would be needed. And this should be given about 12 weeks after the second dose. So if the schedule is interrupted at any point, there's no, it doesn't need to be restarted because of a maximum time that has passed. I hope that answers that question. And the second, and as it relates to the 3-dose schedule, it's the first dose is given, the second dose is about 1 to 2 months after, depending on the vaccine. And then the third dose is 6 months after. And again, there's no maximum timeline. So once the person is able to get that additional dose, even if they have passed the 6-month mark, then they can get it immediately. The second question, the call and recall system. So in countries with an established vaccination program, then invitations are sent out to start screening. If it's age 21, in the UK, they go about 24 and a half years, or 24 years and 6 months, they start sending out these invitations to start at 25. And we don't have such a structured program where invitations are sent out to invite persons to come in. So when it's usually opportunistic screening that is done. And I believe a big challenge with the recall system is, well, one of the challenges is the time frame in getting back the reports and then contacting persons after a lengthy period. So when we're in the public sector, our challenges in obtaining results in a timely manner. So when these reports are ready, then of course there can be challenges in contacting person on the phone. Person might have changed the phone number. Person may not just be answering the phone. So we have to look into using other ways to get in touch with persons. So getting a number for next of kin, getting the address, getting some other way to ensure that we can keep in contact with these persons. Of course, manpower, tremendous manpower is required to do all of this. And that's where cost comes in again. So I believe those are the major challenges with our recall system, but we don't have a formal calling system. It's more opportunistic. And was there another question?
Sure, thank you, Doc. We have another question here that asks, are pap smears every 3 years an acceptable alternative to 5-yearly HPV testing?
Right, so 3-yearly pap smears are recommended. And well, what is also recommended age 30 and over is co-testing pap smears plus HPV screening to increase the sensitivity of the screening process. However, if HPV testing isn't possible, then 3-yearly pap smears can be done throughout a woman's lifetime. In order to meet the WHO targets, however, of attaining just 2 screening tests in a 10-year period, then the pap smears, because of the sensitivity, wouldn't be ideal after such a long interval of 5 years. So looking at the targets, then HPV testing would be preferred in order to meet the targets. However, 3-yearly pap smears are quite fine. In studies looking at the pickup rate, detection rate for cancer with 1-yearly versus 2 versus 3-yearly screenings, there was just a marginal difference in the pickup rate for CIN3 or more when looking at these different time intervals, but the cost was a lot more for 1-yearly versus 2 versus 3-yearly. So on a public health level, on a national public health level, it's a lot more affordable to screen 3-yearly because the detection rate is similar. But on a personal level, if a woman wants to continue yearly screening, then that's also perfectly fine. And I believe there's one from Dr. Tolo in the
yes,
chat.
I have one here from Dr. Tolo. It asks, Dr. Medley, what would you say is the best triage approach in HPV testing, especially given the prevalence of high-risk types outside of 16 and 18?
So that's another excellent question. The WHO in their recommendations had stated these triage options, HPV genotyping and cytology, VIA, and so on. They didn't lean towards any one option. What they did state though is that the HPV 16-18 genotyping may be better, but they didn't really, point down to any one option. The ASCCP, the American Society of Cervical, American Society for, let me tell you exactly what, but the ASCCP, I'll tell you in a bit, they actually recommend doing reflex cytology. All right, so what they suggest is that women who have who are positive for high-risk HPV, then they should go on to have a pap smear done. The previous guidance actually promoted doing HPV genotyping for 16 and 18, and then going to colposcopy if that was positive. But the new 2019 guidance actually states that reflex cytology is the preferred option. So the options are still open. What I've found though in terms of the HPV types, there's variation in HPV types globally. However, when we look at cancer-free women versus women without cancer, I think this is where some of the changes are seen. So generally looking at women with cancer, then types 16 and 18 are still the most common types. And there's a study done by the IARC, International Agency for Research on Cancer, which looked at about 3,600 women with cancer. And they found that it was 16, 18, 31, 33, 35. Those are the top 5 most common. Locally, we have studies here in Jamaica and a study also done in Tobago, which showed that type 45 was the most common. But when we look at other local studies looking at, and that was in cancer-free women, but looking at local studies with women with precancerous lesions or cancer, then again, type 16 was the most common. So I believe this would hold true across the globe. So I would say to answer that, genotyping with 16 or 18 and or cytology is acceptable for triaging positive HPV tests.
All right, thank you, Doc. Are there any further questions at this time? No, I'm not seeing any further questions. Well, on that note, we would like to thank you guys for being with us for session 1 of this morning's conference. I will now hand you over to the moderator for session 2, Dr. Banbury. It's been a pleasure, thank you.
Hi, morning everyone. David, did you have anything before this, an add or so before?
Life is full of twists and turns, slips and falls, and times of change. JN Life Insurance Company is here to help you with individual and family critical illness and whole life insurance plans to cover you and your loved ones when things change. So let's hold our reasoning. Let's talk life. Call JN Life at 876-926-1344 or 876-733-7130. JN Life, we'll help you find a way.
Okay, welcome back to our second session of this symposium. I'd like to introduce our, in fact, before that, just a few housekeeping. The recordings, I saw it in the message, will the recordings be available? Yes, the recordings will be available and can be seen on the YouTube and possibly on the JCS website. There are 5 CMEs attached to this symposium. So these will be emailed to you at the end. All right, and then we'll take the question and answers at the end of this session. So to start off with, let me introduce our next speaker. Our next speaker, Dr. Leslie Mead, is a obstetrician and gynecologist. He's a graduate of the University of the West Indies, where he obtained his DM in obstetrics and gynecology, as well as he obtained a Master's of Public Health, his MPH. He's a fellow of the American College of Obstetricians and Gynecologists and served as assistant treasurer and the treasurer of the Jamaica Medical Doctors Association. He was honorary secretary of the Medical Association of Jamaica in 2018 and now serve as president-elect of the Medical Association of Jamaica and chairs the Pandemic Response Task Force. He's an adjunct lecturer in anatomy at the Caribbean School of Medical Sciences, Jamaica, and serve as an examiner in the obstetrics and gynecology for the Caribbean Association of Medical Council examination, CAMC, His research interests is in adolescent gynecology, sexual and reproductive health, and health management. He has his private practice in obstetrics and gynecology at the Winchester Surgical Center, and also is a medical officer at the UTech University of Technology. He's married with 3 children and enjoys a good game of cricket, both watching and playing. Ladies and gentlemen, help me welcome our next speaker, Dr. Leslie Mead.
Good morning, everyone. I would like to thank the Jamaica Cancer Society for inviting me to present on the topic, cervical cancer, the Jamaican landscape. Is it ethical to introduce mandatory screening? Now, cervical cancer is the 4th most common cancer among women globally. And in 2020, some 604,000 new cases were diagnosed, and about 342,000 women died from it. 90% of these new cases and deaths occurred in low and middle income countries. Sub-Saharan Africa, Southeast Asia, and Latin America and the Caribbean accounted for about 80% of these cases. In 2018, it is estimated that some 56,000 new cases of cervical cancer was diagnosed in Latin America and the Caribbean. And of these, 28,000 women died. In this graph, we see where the age standardized incidence and mortality for the Caribbean and the world and Central America is approximately the same. But we contrast this with Jamaica, whose age standardized incidence of cervical cancer in 2020 is 21.1 per 100,000 and a mortality of 13.4 per 100,000. In Jamaica in 2020, it is estimated that some 386 women were diagnosed with cervical cancer, while about 247 women died. Cervical cancer is the 3rd most frequent cancer in our women, following only breast and uterine cancers. And it is, among the reproductive age women, the 2nd leading cause of cancer. In Jamaica, screening is still largely opportunistic. In a study conducted by the Jamaica Health and Lifestyle Study in 2018, it revealed that women between the ages of 15 and 64 reported that only 5% of them have ever had HPV testing. It also found that only 3% had ever done a visual inspection with acetic acid test as a screening modality. Approximately 70% of women aged 15 to 64 years reported that they have ever had a pap test done. The highest prevalence was seen in women between the ages of 35 and 44 years. For those who have ever done a pap test, it was highest among those who had primary or lower education. Some 75% of these women underwent a pap smear. Those with secondary education, about 64% of them reported that they have ever done one. And those with post-secondary education, some 69%. Of concern is that women within the reproductive age group of 15 to 54 reported that they had a pap test over the last 3 years was only seen in 50% of these women. This is why it is important that we have a robust health promotion and education campaign. Many women in our society are still unaware of the benefits of pap smear testing and HPV testing as tools in early detection and possible cure of cervical cancer. There is still widespread knowledge of the benefits of HPV vaccine. And we have seen this played out when in 2017, the Ministry of Health and Wellness, in conjunction with the Ministry of Education, launched the vaccine initiative where grade 7 girls would be vaccinated. To this point, we should have had at least 100,000 girls been vaccinated, but we have only reached about a third of this, some 32,000 young ladies. And so it is of utmost importance that we intensify our health education and promotion and behavioral change initiatives, whether through social media and traditional media. And at times we may need to have smaller, more intimate meetings to hear concerns of the young ladies and their parents and address them directly. And so we must recommend and continue to do so, that all preteens, those between 11 and 12 years old, be given the HPV vaccine. And these vaccines should be given when they are presenting for other adolescent vaccines. We need to learn as healthcare providers how to effectively answer the common concerns and questions that parents may have about the HPV vaccine. Many patients and their parents are concerned about the fertility issues, and parents are concerned whether or not giving their young girls these vaccines will encourage them to become sexually active. Even when patients and their parents initially decline to take the vaccine, we must continue to bring up these discussions, as it is important that the benefit of the HPV vaccine is known, which is of cancer prevention, whether it be cervical cancer, anal cancer, vaginal cancer, or throat cancer. To this end, the Ministry of Health in 2020 introduced the screening guidelines for 7 priority NCDs, among them cervical cancer. And it recommends that all women between the ages of 21 and 65 should be screened. The frequency of these screens is determined after a risk assessment is done by the physician. And the women may be classified as either average risk or those who are at high risk. Now, due to the low take-up of cervical smears in our country, opportunistic screening is still recommended in all settings, whether it is an STI clinic, the antenatal or postnatal clinics, or the NCD clinics. Screening should be commenced in HIV positive women and trans men at the age of diagnosis, even if they are diagnosed below the age of 21, as we know that the cervical cancer tend to progress very rapidly in these patients. So here I have the algorithm from the Ministry of Health for those who are of average risk. And we define these women as those who do not have an autoimmune condition or an immune compromised condition, such as HIV. Those who are not exposed in utero to diethylstilbestrol or have a history of a previous precancerous lesion or cervical cancer. So we know that our adolescent girls should not be screened, but they should be offered vaccination. For those young women who are between the ages of 21 and 29 years, they should be screened every 3 years with cytology only. As we know, there's a high prevalence of HPV infection in that cohort of young ladies. And once they screen negative, we continue with screening every 3 years. For those women between ages of 30 and 64, they can either be screened with cytology or HPV testing every 3 years. And if they screen negative, we continue screening every 3 years. If they screen positive, they should be referred for specialist care. Those above 65 years should not be screened routinely. For those women who are at high risk for cervical cancer, so those are classified based on them having autoimmune condition or other immunocompromised states such as HIV and other cancers. They were exposed to in utero diethylstilbestrol, and they have a prior history of precancerous high-grade lesions and cervical cancer. For those who are between the ages of 21 and 29, we do cytology only annually. If they screen negative, we continue our annual screens. And if they screen positive, we refer for specialist assessment and management. For those between 30 and 64 years, we screen with either cytology or HPV testing. If they screen negative, we continue our annual screening. If they screen positive, we refer for specialist care. For those that we choose to screen with HPV testing, if they are screened negative, then we continue their routine screening based on their risk assessment. For those who screen positive for HPV types 16 and 18, we refer directly to colposcopy and biopsy for confirmation. For those who screen for other high-risk HPV subtypes, then we refer for cytology testing. And if it is that his cytology comes back as ascus or greater, then we refer to colposcopy and biopsy. And if the cytology is negative, we continue with follow-up in 12 months. So how do we fill this screening secondary prevention gap? Some years ago, the turnaround time for pap smears was between 6 months to a year. This has improved over the recent years from anywhere from 6 weeks to 6 months. But we still need to increase the number of cytologists and cytopathologists available, both within the public sector and the private sector. We desperately need to institute a national call and recall screening protocol for cervical cancer. And I hope that the NIDS program, which should be on shortly, and the Health Information Technology Initiative that was announced recently by the Ministry of Health and Wellness will go a long way with this program. We also need to add visual inspection with acetic acid into our screening options available. This can be done within the primary care setting, as we see lots of our patients being lost to follow-up when they are referred to secondary or tertiary care. We need to increase as well the number of gynecologists and colposcopes within the primary healthcare system. And it's of utmost importance that we increase our health promotion done within communities, whether at our clinics, at our schools, clubs, and religious groups, so that women are aware of the importance of screening. So when we have gotten back an abnormal pap smear or a positive HPV test, patients are largely referred from primary care either to secondary or tertiary care for the confirmatory test, which is colposcopy and biopsy. And at times, to get these appointments can take a long time. After the procedure is done, it takes a minimum of 6 weeks for the histopathology reports to be returned to these clinics. Some of our patients, as I mentioned earlier, are lost to follow-up, and they present years later with advanced cervical disease. It is therefore imperative that we increase the number of pathologists to decrease the time for reports to be generated. We also need to see MRIs within the public sector. Presently, there are none. We need to ensure that there are adequate maintenance of the radiological equipment, as well as diagnostic and therapeutic equipments. And we need to increase the number of diagnostic equipment within primary care so that abnormal pap smears can be assessed there. The National Health Fund continues to provide increased access to common chemotherapy drugs used in the treatment of cancers free of cost, and they should be commended. Cancer patients are largely managed at our 3 Type A hospitals, namely Victoria Jubilee Hospital and the University Hospital of the West Indies in Kingston and Cornwall Regional Hospital in Montego Bay, St. James. Presently, we have 2 linear accelerators in the public sector, one at St. Joseph's Hospital and the other at Cornwall Regional Hospital. Cancer patient surgeries at times have been displaced by trauma, either from motor vehicle accidents or from violence. We need, therefore, to increase the number of linear accelerators within Jamaica, particularly within the public sector. It is internationally accepted that for every 500 new cases diagnosed of a cancer, that we should have at least 1 linear accelerator. And so we need at least 7 linear accelerators in Jamaica to adequately meet the demands of our population. Because of the high demand on the 2 public linear accelerators, they are now having frequent breakdowns and patients having to wait longer times. And so we need to have adequate maintenance of these equipment to ensure that they continue to function properly. We need to expand our ICU and high dependency beds within our hospitals so that when surgeries are done, the patients can be cared for adequately. And we need to increase the the training of radiotherapy and medical technicians to carry out the necessary therapy and maintain the equipment. And we need to treat our precancerous lesions within the primary care setting so we have less patients being lost to follow-up. Rehabilitation and palliation is largely done via the Hope Institute, which serves the entire island of Jamaica as the only oncology and palliation center. Presently, we see where the old cobalt machine at KPH is used for palliation and radiation therapy. And this machine, because of its age, tend to cause a lot of side effects in patients undergoing palliation. We need to have adequate home-based care. We need to improve the availability of drugs. Presently, the NHF has been doing a good job there. And we see where we have palliation clinics at Kingston Public Hospital and the University Hospital of the West Indies. We need to increase the number of drugs for pain management, particularly opioids, as this is what is used most by our cancer patients. We need to increase the number of oncology and palliative centers, not just the Hope Institute, at least one per health authority. And we need to promote more home-based palliative care. And to this end, we need to be able to train more nurses and our community health aides in palliation to go into the community and treat the patients there. Mandatory screening is an interesting topic. And there are different types of mandatory programs. You can either have completely mandatory programs where government requires citizens to undergo screening tests and sanction those that do not comply, whether with fines or with imprisonment. Or you have conditionally mandatory programs where governments or institutions make access to a service or opportunity contingent on participation in a screening program. Now, there was a seminal case in Massachusetts in 2009 where Mr. Jacobson contended that his autonomy was being breached by a vaccine mandate instituted in Massachusetts. The US Supreme Court concluded that states may require vaccination mandates accompanied by a criminal fine as long as they are reasonable. The court further states that the liberties secured by the US Constitution does not import an absolute right. There are manifold constraints to which every person is necessarily subjected for the common good. It further states that states can act to protect persons other than the affected person. And in our case, we were talking about a cervical cancer patient, even at the cost of limiting fundamental individual liberties. When the Jamaican government was contemplating instituting a mandate in Jamaica for the coronavirus vaccines, the Jamaica Bar Association Constitutional Subcommittee examined the rights likely to be engaged by such a mandate. which would impose a mandatory vaccine, and submitted that while those rights would be infringed by such a regime, the infringement would likely to be held to be demonstrably justified in a free and democratic society. Now, when it is ethical and reasonable to limit an individual freedom, the criteria used by the courts to assess reasonableness of limits on individual freedoms include proportionality, precedence, the context, and the sufficiency of access to the service being mandated. So the higher the risk to the population is the higher or more the restrictive limitation on an individual can be infringed. The risk is construed as a combination of risk posed by the disease and the ease of transmission. But for somebody with cervical cancer or the risk of cervical cancer, the risk to the general population of it spreading from one person to the next is minimal. And so I will contend that a mandate based on proportionality would not be appropriate. Now, precedents set by prior limitations is something else that is looked at. And precedents really act as a guide. It has been done before in a similar situation, and so it can be done again. In my research, I could not find where a secondary prevention program has been mandated. We see where vaccination programs, this has been done. And so unless there is an immediate and severe risk, adults should be free to exercise autonomy. Jamaica has a strong and rich culture of vaccination. And school-age children at age 5, it is by law that they should be vaccinated prior to entering school, or they can be barred from entering. However, we've seen over recent past that our society has great distrust in our government. We see it when we introduce the HPV vaccine, where persons refused to be vaccinated because they were concerned that governments had an ulterior motive, whether to affect the fertility of these young ladies. And we also see where this was very evident in the recent talk about mandating COVID-19 vaccine. And anywhere that we may have mandates in such an environment, we tend to have more opposition from those who wish to institute this mandate against. And as such, to attempt now to mandate screening for cervical cancer would cause more distrust and more resistance. If we are going to mandate cervical cancer screening, we must have sufficiency of access to the service, because it would be unfair and certainly unethical to mandate a service when the services are not available. We have seen from my discourse earlier that we have lack of human resource in terms of limited number of cytologists and cytopathologists and persons within primary care to do the screening. We have lack of financial resources. We only have 2 linear accelerators when we should have at least 7. And so it would be unfair to any population when we do not have adequate access. And on this basis, I will say that mandating cervical cancer screening cannot be justified, whether ethically or legally. I look forward to your questions.
Thank you, Dr. Leslie Mead, President-elect of the Medical Association of Jamaica, for such a lucid and very informative talk. We certainly will be looking forward to your continued work and advocacy in your strive to improve or to reduce the incidence of cervical cancer in Jamaica, as well as to obtain, as Dr. Medley mentioned earlier, the WHO Global Initiative. So thank you very much. And I'm sure there are going to be quite a number of questions for you. Our next speaker, Dr. Jordan Hardy, is an obstetrician and gynecologist, and he obtained his Doctor of Medicine in Obstetrics and Gynecology from the University of the West Indies, Mona. He's a fellow of the American College of Obstetrics and Gynecology, and he has special interest in medical education and general gynecology. He's in full-time private practice and is a very avid sports fan. He shares the sentiments of Michelle Obama, who states that communities and ultimately the world are only as strong as the health of their women, end of quote. And by extension, this is his version of thus making the health of the Jamaican woman a national priority. Ladies and gentlemen, help me welcome Dr. Jordan Hardy as he presents Matters Below the Cervix. Welcome, Dr. Hardy. Your mic is off.
Are you hearing me?
We can hear you now.
Thank you. Thank you, Dr. Bambriff, for that introduction. I would like to thank the Jamaica Cancer Society for inviting me to speak at the Dr. Joseph St. Elmo Hall Memorial Lecture Theatre presentation on cervical cancer. Cervical cancer is the leading cause of gynecological cancer-related deaths in Jamaica, and as such, is very important to us. However, this has been covered extensively by my other colleagues. I have been invited to speak about matters below the cervix, vaginal cancer, as vulval cancer was spoken about as well. The objectives of this presentation is to give a brief description of the anatomy of the vagina, speak about the incidence and risk factors of vaginal cancer, mention briefly the pathology, clinical features, investigations, and treatment modalities available to the patients.
Dr. Hardy?
Yes.
Can you please share your screen?
Oh, it's not being shared? Oh dear. My apologies. Are you seeing it now?
Yes, we are.
Yeah.
Perfect. So the vagina is a tubular organ extending from the cervix to the perineum. Anterior relations include the bladder and the urethra, posteriorly the rectum and the anus, superiorly the cervix. The histology briefly, it is composed of stratified squamous epithelium, and this layer provides protection and is lubricated by the cervical mucus. Elastic lamina propria, which is a dense connective tissue layer which projects papillae into the overlying epithelium. A fibromuscular layer comprising 2 layers of smooth muscle, and an inner circular layer and an outer longitudinal layer. Adventitia, a fibrous layer which provides additional strength to the vagina whilst also binding it to surrounding structures. Blood supply. The arterial supplies via the uterine and vaginal artery, which are branches of the internal iliac. The venous return is through the vaginal venous plexus, which drains through the uterine vein and then subsequently into the internal iliac vein. The lymphatic drainage is divided into 3 sections. The superior third of the vagina drains to the external iliac nodes. The middle third drains to the internal iliac nodes. And the inferior third drains to, I'm sorry, I'm having difficulty here, sorry. To the superficial inguinal lymph nodes. Primary vaginal cancer is a relatively rare cancer of the female genital tract, with an approximate incidence of 0.42 per 100,000 women. Metastatic tumors comprise as much as 90% of vaginal cancers. So it is very important to determine, is this primary versus metastatic? And this will impact staging and treatment modalities offered to the patients. Risk factors. HPV. Alemany et al., looking at samples of vaginal cancer and vaginal intraepithelial neoplasia 2 and 3, detected HPV in 74% of invasive cancers that they looked at, and 96% of patients with vaginal intraepithelial neoplasia 2 and 3, with HPV 16 being the most frequently detected type in both precancerous and cancerous lesions at 59%. Other risk factors for vaginal cancer would include multiple sex partners, an early age at coitarchy, and smoking, to name a few. The histopathological types of vaginal cancer. So we have squamous cell adenocarcinoma, sarcoma, and melanomas comprising the most common forms of vaginal cancer, with squamous cell carcinoma being the most commonly represented of all of the tissue groups. Squamous cell carcinoma, as previously said, is the most common form of vaginal cancer with a mean age at presentation of 60 years. It's most commonly associated with HPV. Grossly, it may appear nodular or indurated or exophytic. Adenocarcinoma. This most commonly presents in younger women. It may be associated with exposure to diethylstilbestrol, which is what most of people will remember it as. It may also, however, arise from foci of endometriosis, Wolffian rest elements, and areas of vaginal adenosis. Vaginal sarcomas. The most common vaginal sarcoma is sarcoma botryoides. It occurs during infancy and early childhood and presents as a vesicular lesions, almost appearing as like grapes which protrude from the vagina. Melanomas. The majority of cases arise in women of Caucasian descent. It also presents at approximately 60 years of age. They may appear as a blue-black or black-brown plaque or ulceration, and they are commonly located in the distal 1/3 of the anterior vaginal wall. These tumors have a very poor prognosis. Routes of spread. So vaginal cancers may spread directly to pelvic soft tissue structures, the parametra, the bladder, urethra, and the rectum. Eventually, the bony pelvis may become involved. You may have lymphatic spread. The upper vagina drains into the pelvic nodes and then the para-aortic nodes. The distal 1/3 of the vagina then drains first into the inguinal and femoral nodes and secondary into the pelvic nodes. And the lymphatic spread has direct impact on treatment options available to the patient. You may also have hematogenous dissemination to the lungs, liver, and bone. There are 2 main staging criteria used: the FIGO staging, which is most common, and the TNM. Stage 0 would be carcinoma in situ or intraepithelial carcinoma. Stage 1, which would be confined to the vagina. Stage 2, involvement of the paravaginal tissue, but not the pelvic sidewall. Stage 3, extension to the pelvic sidewall. Stage 4, extension beyond the true pelvis or bladder and or rectal involvement. Stage 4A, extension beyond the pelvis, invading the bladder or rectal invasion, and stage 4B distant organ metastasis. This slide is a little busy. This slide is comparing both the FIGO and the TNM staging, and it is available if necessary. Clinical features of vaginal cancer. So what should we as the clinicians be looking for? Vaginal bleeding is the most commonly reported symptom. It may be reported as postcoital. The patients may report that they have a vaginal discharge, and this discharge may be malodorous. And some patients may even report a mass protruding through the vagina. On clinical examination, most lesions occur in the upper third of the vagina, and you may actually see the mass that the patient is referring to, or you may notice a plaque or ulceration. With local regional disease progression, patients may report urinary symptoms, frequency dysuria, hematuria, or GI symptoms as if the tumor starts expanding posteriorly. So the patients may report constipation or a lower GI bleed. And the patients may report lymphadenopathy, or on clinical examination, lymphadenopathy may be palpated. Is this secondary? So on history, you'd like to ask, does the patient have a previous history of an anogenital cancer? If so, cervix or vulva? What stage was the patient diagnosed? What treatment modalities were offered, surgery versus chemoradiation? Does this patient have a previous history of an abnormal pap smear? Does the patient have a previous history of being HPV positive? Investigations available. So vaginal cytology has been found to identify as much as up to 20% of vaginal tumors. If, however, cytology is negative and there's a strong clinical suspicion that there may be a vaginal tumor, the patient may be taken directly to vaginal colposcopy and a biopsy and tissue. A biopsy taken and sent to the lab for tissue assessment. The role of imaging. The role of imaging is primarily associated with staging, where patients can be offered chest or skeletal radiographs, and plan of management, where, as we have seen, MRI can assist with the size of the tumor, the extent of local invasion, and the presence of lymphadenopathy. A CT scan of the abdomen may also assist with any associated invasion, be it local or distant, and the presence or absence of lymphadenopathy. Treatment options are dependent on the stage of the disease, the tumor size, the location. Is this located in the upper, middle, or lower third of the vagina? And does the patient desire to retain a functional vagina? Treatment options available would include surgery, radiation, or chemoradiation. Treatment options for stage 1 disease. Surgical options for patients who have lesions confined to the upper vagina with some amount of association with the middle vagina, a radical hysterectomy, an upper vaginectomy, or bilateral pelvic lymphadenectomy. For patients with lesions in the lower third of the vagina, a vulvovaginectomy with inguinal node dissection, which would have been extensively spoken about earlier. For patients who are not ideal candidates for surgery or who do not desire surgery, we may offer them radiotherapy. Radiotherapy has been shown to be comparable to surgery for patients with early stage disease for 2-year overall survival, local regional control, or distance-free metastasis. Treatment options for advanced vaginal cancer. There's no high-quality evidence to suggest that chemoradiation is better than radiotherapy alone, so a discussion with the patient is paramount. Neoadjuvant therapy followed by surgery is an option, but not enough data is yet available to make a strong recommendation. Post-treatment follow-up. At the core of post-treatment follow-up is clinical history and examination. So we'd like to ask the patient if they're experiencing any vaginal bleeding, to describe the volume of bleeding and the nature of bleeding, on examination, can you see a lesion or a mass? Or are there any other signs of lymphadenopathy present? Cytology. At this moment, there's insufficient evidence to suggest benefit of cytology as a primary modality for follow-up. Imaging is not routinely recommended. However, it may be of benefit for patients who there's a high clinical suspicion of distant spread. In summary, vaginal cancer is a rare cancer of the female reproductive tract. It's most commonly associated with HPV exposure. Patients commonly present with vaginal bleeding. Treatment is based on the tumor, the size of the tumor and stage. Patients who are diagnosed with early stage disease have a better prognosis with intervention than patients who are diagnosed late in their progression. Thank you.
All right, thank you, Dr. Hardy, for sharing your lecture with us on one of the rare neighbors, in terms of disease, neighbors of the cervix. But certainly, we heard earlier about another neighbor more distal to that, the vulva. So thank you much. They all share the same risk factor for the most part, human papillomavirus. Just a little bit of housekeeping again. For those with questions with raised hands, could you put your questions in the question and answer section, and they will be dealt with at the end of the session. Our next speaker requires no introduction. She is Dr. Dingle Spence. She's a senior medical officer of the Hope Institute Hospital, Jamaica's only dedicated oncology and palliative care unit. Dr. Spence is an associate lecturer at the University of the West Indies, Mona, and is co-founder and co-director of the Jamaica Cancer Care and Research Institute, JACCRI, a non-profit organization dedicated to improving the quality of cancer care and palliative care in Jamaica and the Caribbean. Dr. Spence is also a board member of the International Association for Hospice and Palliative Care, IAHPC, and has research interest in the use of plant-based medicines such as cannabinoids and psychedelics for holistic symptom relief for people with palliative care needs. Dr. Spence has done quite a bit of lecture both locally and internationally, and it gives me great pleasure in welcoming Dr. Spence as she looks at the topic palliative care in the treatment of cervical cancer. Dr. Spence.
Good afternoon, and thank you very much for inviting me to speak at this very important symposium. I'm just going to take a minute and share my screen. Here we go. Okay, I think we're good to go. So thank you again, everybody, and it's been a really interesting meeting so far. So I'm just going to jump straight in and tell you what I'd like to speak about. So I think many of you, as Dr. Banbury has said, have probably heard me speak before, and some of the slides will be familiar. So I just want to reintroduce palliative care, mention that it is a human right. Where does it fit on the continuum of care? And then we're going to look at some recent data on global estimates of suffering for women with cervical cancer, and look at some of the prevalent symptoms and how we might manage those. And then I always like to mention communication skills, and then I'll mention some new initiatives in Jamaica around palliative care. So here we are. This is a definition I always turn to. Palliative care is primarily a response to suffering. And sometimes I say, if you only remember one thing today, can you remember that? So really, palliative care is an active, holistic care of individuals across all ages with serious health-related suffering due to severe illness. And of course, we pay much attention to those, especially near the end of life. And in relieving your suffering, we hope also to improve the quality of life for patients, their families, and their caregivers. So palliative care is not just about the patient, and it's definitely not just about the disease. It's a much more holistic approach that looks at the suffering person, their nearest and dearest. And in 2002, the WHO identified palliative care as an actual human right. So if we're not able to provide palliative care for our clients who need it, we might say that we're actually denying them what is recognized as a human right. And in 2014, there was a landmark resolution at the World Health Assembly that declared, and all of our, all member states were there, our Minister of Health at the time would have voted for this because it was a unanimous vote, that recommended and declared that access to palliative care services throughout the life course is an ethical responsibility of health systems. So again, this is a slide I often use, and we have talked today about the 3 pillars, about prevention with the vaccination, about screening and early detection. We've talked about treatment, but as Dr. Mead pointed out, cervical cancer is very prevalent in our region, and many people present with advanced disease that we may be able to treat, but we may also not be able to cure. And so how are we going to manage those patients? And that's really obviously the essence of my talk today. So where does palliative care fit? So conventional medicine is what we all got trained in, and that is about preventing, fixing, and curing. But of course, we can't do that for everyone, as we have seen today. So what about those folks who we can't prevent their disease or fix it with radiotherapy, chemotherapy, or surgery? So we need to find something, and that is palliative care, supportive oncology, relieving, comforting, and supporting our patients. And palliative care, as I've said before, is focused on people and not diseases, which allows us to look at the greater picture of what the person is dealing with. It can be given at home. And Dr. Mead also mentioned that we need more community-based care, because indeed most palliative care is either delivered from the Hope Institute or the satellite clinics that we do at KPH, National Chest, and I believe UE also has a small palliative care service. So obviously palliative care can be delivered in a hospice. Unfortunately, we don't have many hospices here. We have the Concy Walters Hospice in Kingston, and we have the Hope Hospice in Montego Bay, which is not associated with the Hope Institute in that way. And Hope is actually not a hospice, as many people often think it is. Obviously, we ought to have palliative care in our community hospitals, in our Type B and Type C hospitals, and for sure in our Type A and our university hospital. So let's talk about and put a patient on this trajectory here. So early palliative care. So let's think of a 43-year-old woman with a new diagnosis of cervical cancer who comes in with the usual postcoital bleeding, and she's actually having pain. So early on, she's diagnosed with stage 2B cancer of the cervix, and she needs some palliation. She needs some support. She needs some good pain management. That may be done by the oncologist, but it also may need somebody with a palliative care approach to say, okay, how do I help manage this pain? So we do that, and she gets her treatment, but unfortunately, as time goes on, she has recurrent disease in the pelvis and metastatic disease, and now she really does need palliative care wholeheartedly. Obviously, conventional medicine is going to manage, we need to be managing her UTI if that's what's going on, and so on. So palliative care is not separate. It's in continuity with, and we may need more palliation as the disease progresses, more input from the palliative care team. So I just wanted to show this so that you can see again where palliative care fits, because a lot of people think palliative care is only about end-of-life care, and in a way, nothing could be further from the truth. So people may get diagnosed with cancer. We hope, obviously, that you're down here, potentially curable, early stage, you have your radical treatments, and obviously everybody wants to come out here. But that may not be the case. You may have persistent or recurrent disease, or at diagnosis, it may be not curable. It may be, stage 3B, stage 4A. It is possible to cure that in certain circumstances, but often not. So we offer people palliative treatments. We're introducing this term supportive oncology as well, because often that's what the palliative treatments are: palliative radiotherapy, palliative chemo, with a focus on relieving suffering and hopefully improving that person's quality of life. And then obviously palliative care focuses very much on end-of-life care as well. So I want you to just think about this young woman as we go through the talk, because she every button is pressed here. So she's 43, she's in the prime of her life, she lives with her spouse, she has 4 kids, and she presented, as we said earlier. So she has her radiotherapy and her weekly cisplatin. We have to manage her pelvic pain. Unfortunately, she develops a severe grade 3 skin reaction to radiotherapy. Skin reactions are expected. They are not burns, as we commonly say. They are skin reactions, and some people have worse than others. And in fact, we needed to admit Angela to hospital. Obviously, this is not her real name. So we're providing palliation, we're relieving her suffering, supportive oncology, we get her through her skin reaction. Luckily, we are blessed to have a social worker on our team and a counselor. So both of those services were made available to Angela. She's not working anymore, unlikely to be able to go back to work, at least for a while. So are there benefits she can access? And then unfortunately, a year later, she represents with metastatic disease, recurrence in the pelvis, and bilateral hydronephrosis with deteriorating renal function. So Angela is somebody that we see pretty much every week in our clinic. This is not an uncommon presentation, unfortunately. So why must we have palliative care integrated into the care for women with cervical cancer? Well, we've already said it's a human right. And if we're trying to attain the highest standard of health for our patients, we need to be able to provide some form of palliative care. And we also know that the suffering of women with cervical cancer, and this is proven by data, which you'll see in my next slide, is often more frequent, severe, complex, and often refractory, particularly the pain because of the plexi around where the cervix, the lumbosacral plexus, where the disease can spread, can cause very complex pain syndromes. So the other thing that's a real problem is that cervical cancer disproportionately affects poor women. And as it was said before, a majority of these women are in low and middle income countries where there's very limited access to the earlier stages that we talked about. So we end up with women with advanced cervical cancer, often at presentation, with little access to anything, and hopefully there will be some palliative care for them. So I want to just talk to you about a couple of studies that I was involved in and just share some data with you. So the first one is this study here, cervical cancer associated suffering, estimating the palliative care needs of a highly vulnerable population. So what we set out to do, this is an international group with people from all health regions, many people or a majority working in LMICs, and we wanted to design optimum palliative care for women with cervical cancer. So we were looking at the most common types of suffering and its prevalence and duration. So we did a very large literature review, and then we did what's called a modified Delphi process, where you ask the experts to estimate these types of suffering in their population. And this is basically what we came up with. Sorry. So a high prevalence, this is the results, high prevalence among, so sorry, let me just pause. So what we did is it was the year 2017, and we looked at women who died of cervical cancer in that year. Those are the decedents. And what did we estimate their suffering was? And we also looked at the non-decedents, i.e. women who had advanced cervical cancer in 2017, but did not die in that year. So in the women that died, where was a, look at this, very high prevalence of moderate to severe pain, high prevalence of vaginal discharge and bleeding. And here we're talking about the whole person. At least 1 in 3 people had a loss of faith. And in the Caribbean, the faith base of our people is very, very important in carrying you through difficult times. So in both decedents and non-decedents, there's a high prevalence of anxiety, depression, clearly sexual dysfunction, and financial distress. Think about Angela. Angela's partner may be one of those 40% that she's then abandoned by her intimate partner. So she's there with her 4 kids. Financial distress is very, very common. And so the conclusion that we came to was that among women with advanced cervical cancer, suffering is highly prevalent. We could tell you that anyway, but this is the actual data. And the suffering is often severe and multifaceted. So I'm just going to show you a couple of graphs. So here we go. And I've just highlighted the commonest things. So very high prevalence among the women who died in 2017 of pain. And also slightly less high in the non-descendants, maybe because they're being treated. But here we go, nearly, approaching 50%. And here we are with the malodorous vaginal discharge and bleeding. 60% of women who died in 2017 were estimated to be suffering from that, and about 50% of the women who are still alive. And here's a long list of all the types of suffering that were measured. And not surprisingly, it's much more prevalent in LMICs. So LAC is Latin America and the Caribbean, and this is North America. So if we even just take a comparison of the physical suffering of our women, it's hugely different. These are in thousands, these numbers. So in high income countries, if you just look down the line, the suffering is considerably less than women in our setting, LMICs, who didn't necessarily have access to early diagnosis, treatment, etc. So this is a huge problem. And what are we going to do about it? And this is where palliative care comes in. So what I wanted to do is run quickly through some of these symptoms that we mentioned with some ideas and suggestions for how we would treat them. So vaginal bleeding is very, very common, unfortunately. Vaginal packing is certainly an important but a temporary measure. We can also think about oral medication. I know it's not freely available, but tranexamic acid, both PO and IV, is available at times. However, radiation therapy is really the mainstay of stopping vaginal bleeding, whether it's as a first presentation in a newly diagnosed patient or in the palliative setting. And in the palliative setting, that woman may have already had her radical radiotherapy. So as a palliative radiation oncologist, we have to think quite carefully about how we might administer that dose. But one of the things that we have is that we understand that in the palliative setting, we may not need to worry too much about the long-term side effects, because unfortunately, our patient may not be with us long enough to feel those effects. Pain, we could do a whole lecture on pain, but just to remind you that it's disabling. Advanced recurrent cervical cancer can cause all kinds of different types of pain. And there we are, infiltration to nerve plexi, muscles, pelvic paraortic nodes can cause terrible pain, and referred pain, which is very common in cervical cancer. Fistulas are a huge problem, both urinary and rectovaginal. In the first world, rectovaginal fistulas may be more commonly a late adverse effect of radiation treatment. However, in our setting, they are more commonly caused by either recurrent or primary tumors growing through the anterior rectal wall. So we do need our surgical colleagues' help to do diversions. It must be one of the most unpleasant things in life as a woman to have stool passing through your vagina. Very, very troubling. So this is where the palliative treatments, palliative care, supportive oncology all come together. Edema is also a common issue, particularly with women who already have a high BMI, and then they have pelvic nodes, paraortic nodes. Large tumor burden can cause lower body edema, which can be very, very problematic. We don't have enough lymphedema therapists. I'm not sure we even have lymphedema in the public sector. People have to turn to the private sector to engage this kind of care. So there's so many things that we do need in the public sector. We do use diuretics. We tend not to use furosemide in this case. We tend to use aldactone, which works a little better. And then, of course, we mentioned anxiety and depression. DVTs are a real issue, and you can imagine the challenge of managing a DVT in a lower limb or anywhere, in fact, with a woman who has vaginal bleeding from advanced cancer. So this is where we have to really triage and figure out what is the most important thing that we're looking after. And often this is somebody with advanced cancer, and we probably may not anticoagulate because you're going to make the primary symptom worse. Lung mets are pretty common, and uremia from bilateral hydronephrosis, also very, very common. And again, this is a problem that requires a discussion with the patient, with the family. Are we going to offer bilateral percutaneous nephrostomy tubes in a patient who has advanced metastatic disease? If that's what the person wants, then for sure we will do our best to provide it, but people need to understand that we might be relieving your uremia and your ureteral obstruction to allow you to suffer longer. So it's really a complex discussion that needs to be had with the patient and the family. This was the second piece of the research that we did. This is coming back from some work that was done in 2016, 2017. And what we're doing is suggesting what we call an essential package of palliative care. So this is very basic things that ought to be available even in the poorest of countries. So a set of safe, inexpensive, off-patent medicines, which we are very fortunate to have in Jamaica, and that the NHF for sure supports. We need, especially if we're getting into delivering this kind of care in the community, we need to be able to know that the health centers have catheters available. I know, to say, can we help the family provide a foam mattress? Can the NHS start looking at supporting some very basic things? Some people who can't even afford Inco pads for the bed. If we look at this field manual here, this is designed for people in the poorest countries, and there's some excellent suggestions for these kinds of things in poor rural communities. So I do suggest that the reference is at the end. Basic social supports, as we said, this disease often hits women in the prime of their life. Can we get a social worker in the health centers who can talk to the women about what's available, what kind of supports are there, what kind of benefit packages? Have they thought about what may happen to their children if they don't survive the illness? And of course, again, thank you, Dr. Mead, for saying this, but we need the human resources. We can't have all these fancy ideas of what we'd like to prescribe and to offer unless we can train our people. And right now, at this time, there's very, very little training opportunities for palliative medicine in Jamaica, all the way across, from doctors, nurses, community health aides, and so on. So how do we provide palliative care? So I'm going to skip through this very quickly, as I'm not quite sure how much time I have left, but we need to identify our goals of care. What are we trying to do for this person? Clearly control their symptoms, and always remember we're caring for a whole person and not a cancer of the cervix. There's a woman with that problem and her family. And the goals of care, as we said earlier, are very important. How do we identify people's priorities? First thing we have to do is provide information. And so the communication, as you will see, and I'm sure people are tired of hearing me say this, but communication is a cornerstone of palliative care. That's our tool, talking to people, sitting with you, hearing your concerns, eliciting your concerns, providing information to you and your family. Because if we don't do that, people can't make decisions. They can't participate in their own treatment. And we so need to get away from the paternalistic way of like, this is what we're going to do, this is what's best for you, and we didn't even ask you what you felt about it, or we didn't explain to you clearly. And unfortunately, it is true, because we see people at Hope every single week who didn't know, didn't understand, nobody not tell them anything. And so it's really an issue in our community, and we need to not only train people in palliative care and symptom control, this is part of it too. Communication skills need to be embedded in our medical and nursing schools. So I'm just going to say from this slide, ask the person what they understand, what's going on, what do you understand? Seek permission to say, okay, can I share the information I have? Most people say absolutely, and then share the information and then say again, did you understand? Is there anything else you want to ask? Do you have any concerns? And make sure that when you leave that communication, in that interview, that discussion, that you ask if they have any more questions, and that you also leave with a plan. A plan is critical. Don't just say what you're doing or tell somebody this is what we're going to do. Make sure they understand this is a plan. Are you okay with that? This is how we want to move forward. And again, we find people wanting information, finding the uncertainty, being anxious, might be bad news, but at least you're informed. And a majority of the people that I work with, for sure, prefer to have the bad news than the uncertainty that comes with no information. This is something we don't talk about very often at all. And I would have to hold up my own hand and say, I don't talk about it often enough, but we need to talk about advanced care planning. So an advanced care plan may just be a verbal conversation that you have before you get sick, because you have a family. There's a very good quote, I have an advanced care plan, not because I'm really sick, but because I have a family. And I want them to know what I would want if I became really ill. So we're not necessarily saying we're writing anything down, but we're having a conversation. And so when Angela now gets to the point where she needs a bilateral nephrostomy tubes, she may not have anything in writing because it's so far in our culture, there's no legal basis for it. And it's really not something we do very often. But she might have said to her 22-year-old, you know what, if I reach to the point where I can't come out of my bed and I'm really sick, please don't do anything to prolong my life. She might have said that, or she might have said, do everything. It doesn't matter, it's fine, but have the conversation. And an advanced care directive, as you can say, is something a bit more formal, like a living will. Make sure that somebody decides who's going to make the decisions for me if I'm not able to make the decisions for myself. And also power of attorney is a very, very important thing to think about if you have a severe illness. And who would that person be? Coming up to my last couple of slides. So we're talking about how do we provide this care comfortably. I'm sure you've all seen these slides before, the advantage of being at home, comfort, familiar, secure, private, autonomous. You don't have to have your bath at 4:30 in the morning before the night shift goes off. There's some things you do need to be in hospital for, but maybe coming towards the end of life, you don't want to be in hospital. But how can we support you in the community? Because it may be that your family alone cannot care. So just to summarize, palliative care is a people or person-centered accompanying. I may not be able to fix you, but I can walk with you. It should be integrated into all the steps. If somebody has metastatic disease, we need to be talking about palliative care from the beginning, not waiting till they're a week from they pass away. And we should all have some basic training. So the good news is, just to say, this is what we should be doing. We should be training people at this base of the triangle so that we have many healthcare professionals in the community, in our type B and C hospitals that understand about a palliative care approach. I guess you could say specialist palliative care is what we provide at Hope, but that is the tip of this iceberg. We need to be filling the base and the middle of this triangle by empowering ourselves and our fellow healthcare professionals with appropriate training and mentorship. And a new initiative, you'd be delighted to hear, I'm very excited about this. The Ministry of Health and Wellness is introducing a primary care renewal plan. I say we because they're looking to Hope to support this, community-based palliative care. So we're trying to get palliative care into the health centers so that those women who are suffering at home do not have to spend several $1,000s to come to Hope or KPH in a taxi when it's no longer appropriate. So this is literally happening as we speak. And along with JACRI, because without JACRI, Jamaica Cancer Care and Research Institute, and our supports at Harvard and Mass General Hospital, along with teams in Jamaica, we are putting together a diploma in palliative care that would be accessible. Unfortunately, it is only at the minute going to be accessible to physicians who completed their SHO year, but it should be launched through UE, Department of Community Health, this September. So watch this space. We're very excited about being able to offer that opportunity. Here are my references, and I thank you very much for your attention.
Well, thank you too, Dr. Spence, for a very interesting and eye-opening lecture. At this point, I'd like to invite all of our speakers back. I think there are a few questions for you. I think there's a question for Dr. Mead from Dr. Fletcher. He said, you said cervical cancer is less common than endometrial cancer in Jamaica. And what was the reference for that?
Well, in my presentation, I did mention that uterine cancer have surpassed cervical cancer. the World Health Organization International Agency for Research on Cancer, GloboCan 2020, and it can be forwarded if necessary. It showed that in 2020, we had 421 cases of uterine cancers, which represent 11.9% of cancers in females of all ages in Jamaica, while we had 386 cases of cervical cancer, representing 10.9% of all cancers in females in Jamaica. So it can be forwarded if necessary.
I think the Jamaica at the university may have different figures in terms of the in the Department of Pathology, in terms of the incidence of cervical and endometrial cancer, where cervix is probably a little higher than endometrial at this time.
Well, that is likely, but
Yeah.
the cancer registry there mainly looks at Kingston and St. Andrew.
Yeah.
We have a few more parishes to go.
Okay. All right. Another question for you. Is brachytherapy available in Jamaica? If not, what are the challenges?
Okay. Sorry, I didn't hear. Go again, please.
Brachytherapy available in Jamaica? If not, what are the challenges?
Well, in doing the research for this topic, I did not come across that brachytherapy is available for cervical cancer patients in Jamaica. I'm not sure if persons like yourself at the university have done that, but I did not come across that. And if it is not, I suspect it's a cost issue more than anything else.
Dr.
There is.
Bambry,
Yeah, Dr. Dingle Spence, yes, absolutely. Yes, Dr. Spence.
Yes, so brachytherapy is available in Jamaica. We've had it for many, 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 many years. In fact, my own father used radium, so that's very, very ancient times. That would have been in the 60s and 70s. And so the first brachytherapy was using radium. We have brachytherapy at KPH. We use cesium. And so we do brachytherapy insertion after radical radiotherapy. However, the system is old. It is not something we're particularly proud of, and we are in the process of moving from this older type of brachytherapy, which is an essential component of treating cervical cancer, to a newer method, which is using what we call high dose rate brachytherapy, where the treatment lasts 15 to 20 minutes. It does require to be done 3 times, whereas what we currently use is the cesium insertions, which stay in from 24 to 36 hours, whereas the high dose rate using iridium, there's 3 treatments over a period of about 10 days. And the treatment lasts about 15 minutes. The woman does need to be sedated, certainly, if not anesthetized. So we do have brachy. We're trying to move from an older system to a more modern system that goes along with the installation of the 2 public sector LINACs that we currently have. So that's where we are.
Thank you for that answer, Dr. Spence. And there's another question for you, Dr. Spence, while you're still on the floor. What if patient requests euthanasia?
So, it's a very interesting question. And I have been now working, having come back from my training in 2002. This is my 20th year working in palliative care and oncology in Jamaica. And I can think of one person in 20 years who has said, can you make it more quick? So one of the things I would say, it's completely not part of our culture. What I find is that the faith base is really, really important. And people will say, when you break bad news to them, or they know they have severe illness, they turn to God, basically, and they will say, if it's God's will, we know we all have to die of something, and we know that God's works through you and the nurses and the rest of the team. So do what you can for me until. So Dr. Guthrie, I think that might have been your question. Nobody ever asks us that. Honest truth, people do not say, can you bump me off quicker, doc? They just don't. And one of the things we're missing from our team is that chaplaincy person. So I'm not really talking about your pastor, although we absolutely want your pastor. We're talking more about somebody who is more on a spiritual level that can help you with considerations about life and death. That is not necessarily a religious focus. So that is a person that's absent from our team currently. And it's a really critical, important aspect. So thank you for the question, though. Appreciate it.
A question for me, Dr. Spence. Advanced care directive is something that we do not routinely do in our hospital setting. Do you think that this should become more formal and actually have something documented that goes on the patient's file, so that a patient in advanced disease that comes in, if this patient's arrest in hospital, then the entire staff knows what to do, instead of someone deciding to go jump on this lady's chest, trying to resuscitate unnecessarily?
Absolutely, Doc. You know, and it is something that we really talk very little about in our culture and in our medical settings. And it comes right back to that communication. Does the woman understand how ill she is? Does her family understand how ill she is? But before you even get there, should we be talking about that? And I think we should. And I'm actually going to call the name of a colleague of mine, Patrice Dwyer, who's actually produced a booklet called It's Your Life. Sorry, I can't remember the exact name, but it's actually a booklet that walks you through everything. Do you have a plan? It's like a life care plan. What's going to happen to your Facebook site when you die? I mean, that's kind of, you know, but, you know, have you talked to anybody? Do you have a living will? Do you have something that says, you know, if I get really sick, if I get run over by a bus tomorrow and I'm in ICU and I'm brain dead, do I have a directive that says, don't keep me alive? And we should all be doing this. This is not just for people who get diagnosed with cancer. We should all be thinking about it. And one of the things that we should also be doing is encouraging our lawmakers, because right now, if I write an advanced directive, it's not recognized in the court of law in our country. So that's something that we need to be moving towards. It might stand as a piece of information that people would recognize as your voice, but it's not a legal document because we don't have laws that govern that kind of thing as yet. In Jamaica, I know Cayman Islands is pushing for that, but I don't think anywhere else in the Caribbean has reached that far.
Excellent. Okay, thank you. It's a question for Dr. Hardy. Does HPV testing have a role in screening for women post-hysterectomy who had history of cervical pathology, or in women whose screening history is unknown?
Thank you for that question. They have looked at cytology, as in pap smears, extensively for patients as it relates to vaginal cancer, and they have found that there has been no benefit for cytology. As it relates to HPV testing, I am not aware of any studies available that speak to HPV screening as a form of screening for vaginal cancer, or in the follow-up for patients who have been diagnosed with vaginal cancer and had therapy.
Okay. Are there any other questions? I think your question was answered, Dr. Tolo, by our advanced directive supported by law in Jamaica. Yes, it's not. Stated by Dr. Spence. Are there any other questions?
Dr. Montgomery?
Yes.
We do have a Dr. Neil Prasad Singh, but his hand is up in the as an attendee.
I'm not seeing a question.
I think we need to probably ask him to type it.
Dr. Singh, can you type your questions in the question and answer so we can see? No. No. Would you allow him to speak, David?
Sure.
Dr. Singh, can you voice your question, please?
Last week, it was announced that they discovered that prostate cancer, its spread was facilitated by bacterial infection in the urinary tract. And they postulate in the theory that although it might be caused by a virus, the bacteria, concomitant infection with the bacteria, might be interfering with the body's immune system and therefore these patients needed to be treated with antibiotics. Point about it is from H. pylori was discovered as a cause of cancer. It has given us a model that we should look at other things causing cancer.
Dr. Mead, thanks, Dr. Singh, any feedback on that? Is a comment more than a question? No?
I'll just jump in and say that, you know, cancer gets classified as a non-communicable disease, which is on the one hand is a good thing, and the other hand is a little bit of a misnomer, because obviously we spent a whole day talking about a communicable disease. But it would not surprise me that in the future that we find out that prostate cancer is indeed caused by some kind of potentially infective or transmissible organism. I think we just don't know yet. When we were in med school, we had no idea that stomach cancer could be caused by bacteria. So, you know, who knows where we're going to go. But I think the science is developing, and I'm sure we'll get those answers hopefully in the next decade or sooner.
All right, thank you, Dr. Spence. Thank you, Dr. Singh, for that comment. So if we have no further questions, I want to say thanks to our sponsors from the Miami Cancer Institute, South Florida Baptist Health, for their continued support of this type of symposium. The Jamaica National Life Insurance, they say, we'll help you find a way. Jamaica Cancer Society, the organizing committee of this meeting, just want to give you thanks. It was well run. To our ICT personnel, David and Richard, a very well run program. Yes, David.
Sorry, Dr. Bammer. We do have one more presentation from Ms. Sharifa Grandison, who is
okay, I didn't see that.
Okay, no problem. But she's ready and standing by.
Okay, sure. Okay. She's from, sorry, Dr. David. Sorry, Sharifa. Glad to have you from Jamaica National. Please go right ahead. So sorry about that. Well, I was giving you props already.
Thank you, David. Good afternoon, everyone. All right, so just quickly going through, all right, so there are a few questions that we can ask ourselves as we go along. So first of all, you know, think about it. What happens as it relates to the various responsibilities that you have in the event there is a diagnosis of a critical illness, talking about like mortgages, educational loans, you know, investments that you may have accumulated over time. You know, you have your financial goals. What if you have to redirect these funds to medical costs? What if, you know, you pass away? As it relates to illnesses, that critical illnesses that may be diagnosed, what if, you know, an illness recur? And what if there is a second diagnosis, another critical illness that is diagnosed? So within the JN group of companies, you have JN Life Insurance Company Limited, and we have policies that answer these questions. And you have a combination of individual and family plans as it relates to critical illness and as it relates to whole life. Whole life is what you see here referred to as burial plans. So looking in light of what we have been discussing today as it relates to cervical cancer, looking at critical illness plans, the individual critical illness plan as well as the family critical illness plan are what you call simplified issue, right? And as it relates to, 1 minute, sorry about that. As it relates to eligibility, it's age 18 to 60. The plan itself expires when the insured attains the age of 75 or the 20th policy anniversary date, whichever is later. We offer coverage of $1 to $6 million, and the coverage is reduced to 50% at the age of 70. Now, I know this is a chart that everyone would want to look at as it relates to the different illnesses covered under both our critical illness plans. And as it relates, pointing out is that all the plans I'm sharing right now, they are non-medical plans, so no medical examination is required. But for the critical illness plans, we have a couple questions we'd ask proposed lives to be insured in the interview to know if they would be eligible. Now, as it relates to the two benefits which set our individual critical illness plan apart, the first is the reoccurrence benefit, because we do know that some critical illnesses may reoccur. And so if there was a first diagnosis, because that is the point at which a lump sum payment would be paid based on the amount that was chosen as coverage, if there should be, if the insurer should continue to make payment after that first diagnosis and payout was received, and at least 12 months should pass thereafter, and another diagnosis is made of the same illness, they will get that lump sum again. And as it relates to the additional occurrence benefit, if they were diagnosed with a critical illness first, one that was covered by the plan, and then at least 6 months after another illness covered is diagnosed, they will get the money again. So for both the reoccurrence and additional occurrence benefits, there's no maximum number of times that we will pay out as long as the respective wait periods have been satisfied. So for the reoccurrence benefit is 12 months. For the additional occurrence benefit, it is 6 months. Now, as it relates to this benefit, if there was no claim on the policy and the insured should pass away, the sum of all the premiums paid up to the point of death of the insured would be paid out to the named beneficiary or beneficiaries. And as it relates to the point at which the plan expires, if at that point, up to that point, there was no claim on the policy, the main insured will receive a sum of all the premiums paid up to that point. All right. So as it relates to ambulance benefit for both the family and the individual plans, the insured can access up to $15,000 to cover that expense. And even if they should pass away due to complications related to the illness, then the beneficiary will get that amount. As it relates to unemployment benefit, whereby monthly premiums can be waived for up to 2 months, as noted here, that is accessible once the plan has been enforced for at least 6 months, payments have been made for at least 6 consecutive months, and the payments were being made through payroll. And of course, JN Life would have to get the requisite notification from both the owner or the employer within 30 days of those payments ceasing. Now, as it relates to the wait periods, they are outlined here. For the critical illness, the individual critical illness plan, the wait period is 30 days. So as early as 31 days of the plan being in effect, if there's a diagnosis, the insured can access funds. Now, reinstatement, there are different reasons why a policy may lapse. And so should this happen, the policy may be reinstated within 30 days of lapse, and within 6 months of lapse, it may be redated. Now, moving on to our family critical illness plan, because we know that persons do have their family members that they would like to get coverage for as well, because critical illness does not affect a particular age group. There's a high incidence of critical illness diagnosis in children as well. So with that said, children can be added to the family critical illness plan as shown here from birth to 26. As it relates to other family members who are eligible for being on the plan is spouse and parents, and the expiration date is the same. Now, the death benefit, if there is a surviving spouse, the surviving spouse may take over ownership of the plan, but if there's no surviving spouse, then the beneficiary would receive the sum of all the premiums paid up to the point of death, provided there was no claim on the policy, right? No claim paid. And for the family critical illness plan, the wait period is 90 days. Now, as it relates to pre-existing condition, because some persons may have a pre-existing condition, and this applies to both the individual and the family critical illness plan. If that condition is pre-existing for at least 12 months of the life of the plan, and it should then give rise to a critical illness that's covered under the plan, they will get the payout. So having covered both critical illness plans, I will just move into the whole life plan, looking specifically at the individual whole life plan first. Now, both plans are guaranteed issue plans, meaning it doesn't matter if the person has stage 4 cancer.
they can get the plan, right? And as it relates to the eligibility age for the individual whole life plan is 18 years to 76 years at the time of submitting the application. And you stop paying premium when the life insured attains the age of 76 or the 20th policy anniversary date if later. And even though they stop paying the premium at that point, they're still insured up to age 100. Now, the payout for death benefit is specified here in this chart as it relates to death outside of an accident. And point to note that with the individual whole life plan, we offer coverage up to $5 million. And then there is an added benefit, the accidental death and dismemberment, which can go up to the same amount as the sum insured. So say someone took $5 million coverage and also $5 million accidental death and dismemberment. Should there be death due to an accident, then it's instant payout. There is no wait period, and it is twice the coverage amount that the person's beneficiary will be getting. So it's $5 million with the coverage, $5 million for the accidental death and dismemberment. Now, as it relates to terminal illness, for terminal illness, we at JN Life will pay as a living benefit to the life insured. Once there is such a diagnosis, 50% of the applicable death benefit upon receipt, of course, of satisfactory proof of this diagnosis, and the payment will reduce the basic sum insured by 50%. And as it relates to the accidental death and dismemberment, if there is dismemberment due to an accident, then a percentage of the accidental death and dismemberment would be paid out so the insured can deal with the injury. Later on in life, when they pass on, the coverage amount will be paid out to their beneficiary to deal with those final expenses. And that's why you see here, we have the notation of double indemnity and a living benefit. Now, moving on to the family indemnity plan, the family whole life plan. The eligibility age here is birth to 65 years old, and it's for both family plans, the critical and the family indemnity plan. There are 6 spaces on the plan, including the main insured. So that's the main insured, spouse if there's a spouse, children, parents, maximum 2 parents, whatever the category, right? And the same with the children. Now, this is a chart I know persons might find very interesting. In the second column, you have the coverage amount offered for the family indemnity plan. So what it is saying here is that whatever the coverage amount is chosen, each person on the plan is covered for that amount. And the last column shows you the monthly payment for the respective coverage, all right? Now, as it relates to payout on the family indemnity plan, the wait period is 90 days. So if the main insured should pass away within that window of the plan being open, then it's the basic premium paid up to the point of death that will be paid out as death benefit. If anyone on the plan should pass away between the 4th to the 12th month, it's a maximum $1 million that we will pay out. 13 months and over, the full benefit. And this for persons who may have taken the $1.25 or $1.5 million coverage. Now, as it relates to terminal illness, we at JN Life will pay as a living benefit to the life insured, 50% of the applicable death benefit. But the maximum that we will be paying out is $1 million, and of course, with the satisfactory proof of the terminal illness diagnosis. Now, as it relates to coverage for critical illness, this is a sweetener for the plan. We offer coverage for 3 critical illnesses, blindness, deafness, and major burns at no additional cost to the insured on this plan. So what it means is that if anyone on the plan should be diagnosed with any of these 3 illnesses, the coverage amount will be paid out to deal with the illness. Later on in life, when they pass on, the coverage amount will be paid out to deal with the final expenses. Now, accidental death benefit. There's no dismemberment here, but accidental death benefit is an added benefit to the family indemnity plan and eligible for persons up to age 60. And once on the plan, they enjoy this benefit up to age 65. So just a summary here, 90 days wait period for the family indemnity plan, no wait period for the accidental death and dismemberment, both on the individual and the whole life plan. Even if it is one day the plans are in effect, once there's death by accident, it is instant payout. So that brings me to the end of my presentation. I'm sure there may be questions. Please feel free to take down my contact number, email address, and contact me. I'll be happy to have those discussions. Thank you so much.
Oh, thank you very much, Mr. Anderson. I'm just curious. I probably didn't hear correctly, but did you say someone with an advanced cervical cancer could still apply for an individual whole life plan, which includes a critical plan? Is that correct? Yes. And how soon? Okay. So what about a person who already diagnosed with cancer? Can they apply for critical care plan?
No, because it's not the critical illness. But one of the things to know, why the critical illness is unique, what we have to offer the individual specifically. How critical illness plans work traditionally is that once there's a diagnosis and that lump sum is paid out, the plan ends and you can't get a new critical illness plan again. So that's why if someone is already diagnosed, they wouldn't be eligible for a critical illness plan. But then for our individual critical illness plan, if our insured owner should decide to continue making those premium payments after the lump sum has been received, then the plan stays in effect. And that is where now additional and recurrent benefits are there. Should they be, diagnosed again or another critical illness cover is diagnosed, they can access the funds.
Oh, thank you.
You're welcome.
Well, I'm not seeing any questions from the audience to you. I'm sure they will be contacting you through your contact information. So thank you, Mr. Anderson from Jamaica National. And as you said, we'll help you find a way.
Definitely.
Is that correct? All right. All right, thank you very much. So I continue to give vote of thanks to the Jamaica Cancer Society, our IT people, David and Richard. To all of you, the audience who attend well. Even before that, can I thank our presenters, Dr. Medley, Dr. Gatliff, Dr. Taylor, Jody, Dr. Leslie Mead, Dr. Jordan Hardy, and Dr. Spence. Thank you so much for your lecture today. I'm sure we have learned quite a bit and will be utilizing some of what we've learned in our own practice and in our own, individual communications with others as well. For our first moderator, Dr. Jessica Henry, thank you so much. Just remember that there are 5 CMEs attached to this symposium, and these will be posted to you. And the recordings of this is going to be on YouTube. Let me not keep you away from your Sunday dinner and your family. So thank you once again for being here, audience. All of you could have been somewhere else, but you have decided to spend the time this morning and afternoon with us. Thank you so much. And we see you again next year. Thank you. Have a good evening.
Life is full of twists and turns, slips and falls, and times of change. JN Life Insurance Company is here to help you with individual and family critical illness and whole life insurance plans to cover you and your loved ones when things change. So let's hold our reasoning. Let's talk life. Call JN Life at 876-926-1344 or 876-733-7130. JN Life, we'll help you find a way.